certificates of attendance for your CPD records. These will be completed automatically next week. So we'll download the data from Zoom that shows who's joined the webinars, who's been watching from the lobby, how long you've been in attendance, and we'll get those certificates sent out to you automatically. So you don't need to worry about making a request or emailing us. We will get that done over the next few days. Finally then, a couple of things for your attention within the platform. We have an expo area or some exhibition profiles or exhibitor profiles. These are the sponsors that have worked with us in terms of ensuring that we could bring this to you free of charge. So Elanco are the headline sponsors, and we'd like to say a massive thank you to them. We also have Bowringer, who are the gold sponsors. We'll be hearing a little bit more from them through the day, as well as from elearning.vet and CAM. And whilst we're waiting for a few people to log in, I'm just going to share a video with you about elearning.vet, which is the CPD platform I run, just to show you sort of what we're about. So whilst we're getting this first talk ready, I'm just going to show you this talk to start with.
elearning.vet, the veterinary CPD specialist. Bringing you the highest quality veterinary CPD from industry experts and keynote speakers. A new way of learning featuring monthly mini-series, expert panel discussions, interactive CPD quiz nights, and plenty of case studies. elearning.vet, a new way to learn. Sign up now.
So there you are, that's elearning.vet. The idea behind elearning.vet is trying to make CPD, veterinary CPD, more interactive, more engaging. And these events are part of that as well. And we have some varied formats coming up today, including a quiz. So hopefully you'll enjoy that. Right, I'm going to bring Hannah Capon and Sarah Heath into the webinar now. Just make sure that obviously we don't have any lobby live streams playing in the background, Hannah, and then I shall hand over to you.
Thank you very much, Paul. Oh my God, it is third day. I hope that you're all as exhausted as we are. It's been non-stop. So we started on Friday at 8 a.m. We finished at nearly 11 p.m. that day. So please do go and check all the bite-sized webinars. There are loads. And we had really good feedback about numerous ones of them. Then yesterday we had a jam-packed day starting at 8, finishing at 10 p.m. So there's another 14 hours of learning there. So go and have a look. They're all watch on record now. But I'm really excited to introduce to you a really dear friend of mine. This is the lovely Dr. Sarah Heath. Now, Sarah and Claire pre-recorded. And because they have got so much to tell you, like seriously, put these two together, they just can't stop educating. It went on a little bit long. So we haven't got time for Q&A at the end, but we have got time for questions during the presentation. So Sarah has kindly joined us. She's going to be backstage with me and she'll be answering the questions via the texty. So if you've got questions during the presentation, don't wait to the end because there is no end. Get them down and she will be answering them as we go. We also then have the opportunity to do a face-to-face questions on the 4th of June, 7 p.m. on canine arthritis management. But I will be sending out loads of adverts. That's the cue for you to go and follow our Facebook page, join our member zone, know what's happening. We will be back on the 4th of June to answer those questions. So we're going to head backstage and crack on with the webinar.
Thanks very much for that introduction, Hannah. It's great to be here at the Chronic Pain Symposium. What an event, and congratulations to CAM for putting it together. So we're going to be talking about neuropathic pain now. I'm joined by my friend and colleague, Claire Rusbridge. As you'll see from this introductory slide, Claire is a European and RCVS veterinary specialist in neurology, and I'm a specialist in behavioural medicine. So we're going to be talking to this title, which is Neuropathic Pain and Behavioural Change, a Multidisciplinary Approach, because we both come from different disciplines, but these are the sorts of cases that we often work on together. So what are our learning outcomes then for this presentation? Firstly, we're going to think about understanding the concepts of nociplastic or maladaptive pain and neuropathic pain. Think about that link between emotional and physical health components in these types of pain, and consider the range of behavioural responses that can occur as a result. And then we're going to think about the process of identifying an animal with neuropathic pain, as well as considering some of the approaches to the treatment of them. So we've got a lot to get through in this next hour. So I'm going to hand over now with a little question to Claire. So Claire, what exactly is neuropathic pain and maladaptive pain? How do these terms link together, and can different forms of maladaptive pain occur at the same time?
Thanks, Sarah. So we really have to consider pain in three ways. First is nociceptive pain, and this is pain that is perceived in a normal functioning nervous system. So if I stand on a tack, then that hurts my foot, and two things happen. First of all, there's a reflex called the withdrawal reflex, which takes my foot away from the site of pain, but then that information goes up to the brain and is perceived as pain, and then that stimulates some sort of behavioral response from me. So I look down at my foot, take the tack out the foot, perhaps put the tack away, and make it safer. The next type of pain is nociplastic. And nociplastic is fairly new term. Some people won't have heard about it. And actually, sometimes people call this maladaptive pain. Nociplastic pain is an abnormal pain state caused by ongoing inflammation and damage of tissues rather than nerve damage. And it's to try and encapsulate those pain states that result in an abnormal functioning nervous system, a central pain sensitization, but actually aren't as a result of a damage to the nervous system. So that will be very important to people attending this Congress, because osteoarthritis is part of that group. And so pain resulting from visceral damage, for example, a pain that you get with bowel pain, idiopathic bowel disorders and idiopathic cystitis, that's that sort of thing. So it's a huge group. In humans, it includes fibromyalgia. And then after that, we have neuropathic pain. And this is an abnormal state because of damage to the nervous system. And that damage could either be the central nervous system, so the brain or the spinal cord, or it could be damage to the peripheral nerve.
So when we think about these types of pain, Claire, what about whether they occur together? So you can explain a little bit more about these pain syndromes for us.
Well, I've listed them here, Sarah. These are all the sort of chronic maladaptive pain syndromes. Chronic pain in animals is not as well defined as in humans, and even in humans they argue about it. It's normally regarded in humans as pain that has a longer duration than 2 months, and in animals they sometimes question it should be a shorter period than that because they have shorter lives. But we'll say pain has been long-standing, and they can be divided into chronic musculoskeletal pain, so things like osteoarthritis, chronic visceral pain, so things like inflammatory bowel disease and cystitis, chronic peripheral neuropathic pain and chronic central neuropathic pain, cancer-related pain, which is super underdiagnosed and recognized in animals and in humans. But when we actually consider that, there can be quite a bit of crossover between other pain groups. For example, if you have a tumor that is compressing the spinal cord, one could argue that that is also potentially going to cause chronic neuropathic pain. But because it compresses the meninges in its own right, the meninges have nociceptors, then it has its own classification in itself. And then the other thing that is often not looked at enough is pain as a consequence of treatment or surgery or radiotherapy, because that definitely happens in humans and it definitely happens in animals as well. And then a big group that I may see in my pain clinic is pain after surgery or after trauma. So, for example, oral pain after tooth root damage. Those trigeminal nerve endings are incredibly sensitive. Pain after orthopedic surgery and prolonged retraction of sciatic nerves, for example, thoracotomy pain, amputation pain, and where there's been surgery, where there was inadequate intra and post-operative pain control, because if you don't adequately pain relieve animals, then you can much more likely to leave them in a post-operative pain state.
That's really helpful. So what about the way in which this is generated, the neurology of it, if you like? You're the specialist in this area. What about what's happening in terms of the neurology?
Well, I'm going to talk through the kind of neurotransmitter level when I'm going through in pain treatment, because I thought, well, we'll only have to deal with the neurotransmitters once then. But once you get the signal coming from the nociceptor, it goes into the spinal cord at an area called the dorsal horn, and then it's transmitted up the spinal cord by various different routes, and then eventually hits the cortex. And we often refer to that cortex as the pain matrix. And that's not because there is an area in the brain called the pain matrix. That's really to describe a number of different areas which are not very anatomically close to it. The first bit that happens is that it goes to the amygdala. And the amygdala are very small areas in your brain that are encode and consolidate the emotional memory of the event. Because it's very important, if you have pain, you actually remember you were hurt, because then you can avoid it. Because the whole process of pain is that you learn from that experience. So if I learn that there was a tack on the floor, then I might avoid that, walking on that area of the floor in the future. If we can apply that to animals, then if they learn that going into a vet surgery is likely to result in pain, then they'll be unwilling to go into that vet surgery again. Then it goes to the hippocampus. The hippocampus relies quite close to it, and it's labeled in purple there, and that converts that short term to that long term memory. And they both together regulate your fear response by activating the hypothalamic pituitary adrenal axis. So, the hypothalamic pituitary adrenal axis will also influence that area. So, for example, if you are being chased by a lion, then you're obviously quite fearful of that lion, and when they if they were to catch you, if you're an antelope, for example, and you had a broken leg, you may still run on that broken leg, because the hypothalamic pituitary axis kicks in with your fight or flight response to make you flee from that. But these areas will also activate your fight or flight response and make you want to avoid that area. And then our next bit of this cortical limbic circuitry is the cortical areas, so things like the prefrontal cortex and the cingulate gyrus, and they receive an awful lot of inputs, the somatosensory, visual, auditory, and emotive inputs, and they plan your complex cognitive behavioral response. So this is where you kind of may rationalize it. Okay, maybe I was hurt by a tack when I walked across the room last time. What are the chances of being hurt by a tack next time I walk across the room? As a human, I may be able to put in a bigger interpretation into that, because I have a bigger forebrain. Animals, of course, may not be able to make that cognitive jump. And that's, I think, something you're going to be talking about, Sarah. And then when we look at the pain matrix, we can really divide it into three sort of areas. And so it's connected to this hypothalamic pituitary axis, and that will input your decision making, your emotional regulation, and your memory. And they will also modulate your acute pain, but it's very important. This is critical for the chronification of pain. So all these areas are really critical for making pain go from that acute to chronic. And the thing is, these areas overlap. And so this cortical limbic circuitry that's involved with emotion, it's obviously overlapping with pain. And that means that chronic stress can actually open the gates and make you more susceptible to being painful, and vice versa. That when you are painful, you're more susceptible to having mental health problems and even very complex neurobehavioral syndromes.
So let's look a little bit more then about the function of the pain matrix.
So the function of the pain matrix, we often divide it into three hypothetical areas. So the first area is your sensory discriminative dimension. So this tells you where the pain is and how severe it is. So I stand on the tack, I think, ouch, where is that? It's my foot. And therefore that will direct me to deal with that. The next area is your affective motivational width, which is your emotional response to that pain. And so being hurt obviously stimulates an emotion. It might make me angry at the tack on the floor. Why is that there? All the health and safety of it all. And then the next stage is our cognitive dimension. And this is where pain demands a behavioral response. I need to do something about the fact that I have been injured by a tack. Right, I'm going off to the people in charge of health and safety and ask why it is that they've allowed a tack on the floor which has damaged my foot. I might also self-reflect and think, why am I walking across this floor in bare feet, and put something more protective in. And this cognitive defector will affect all other cortical processes as well. So it has to be integrated with your other decision making. So you may decide to ignore that pain if there is something else that is more important to you. So if I have incredibly severe dental disease, like many, many cats, I may decide to ignore that pain because I want to eat and I don't want to starve to death. And I think there's an important lesson there. Just because an animal is eating doesn't mean that they're not painful. Most animals don't choose to starve themselves to death. And it's very important to remember with this cognitive dimension that pain predisposes, as I've said before, these stress-related behavioral disorders and vice versa. And that's what really my question for you, Sarah, is what sort of behavioural presentations do we see with neuropathic pain?
Yeah, this is where it gets really interesting from a multidisciplinary point of view and why we work together on these cases. Because when we're dealing with the behavioural side of things, there are quite a range of different ways in which behaviour can be influenced by the emotion of pain and the physical sensation of pain. So let's think of it in terms of the altered sensations to start with. So neuropathic pain, as you've just described, when it's associated with those peripheral nerves, can lead to quite altered sensations in the skin, for example. And we sometimes see behaviours which are reported by caregivers as a behavioural concern because they're a behavioural response, but they're coming from that abnormal sensation. So some examples of that might be changes in their facial expression, so some grimacing, which we look here, these examples from these Cavaliers photos, thankfully coming from Claire here, looking at the change in facial expression, sometimes referred to as a pain face. But there are obvious behavioural responses like rubbing of the head or shaking of the head. Obviously, when we get these sorts of responses, we might have other things on our mind, like maybe dental pain with the mouth rubbing or ears hurting with the head shaking. But we need to remember that it can be more complex than that. Of course, we want to do a clinical examination and make sure we've ruled out those other options first, but neuropathic pain could be responsible. And then because of those peculiar sensations, we may also get things like nibbling at the skin or maybe abnormal movement of the skin, so rippling responses. Now, one thing I haven't included here in this particular slide is scratching, Claire. And I did that because I know you always have something to say about making sure we don't confuse scratching with neuropathic pain, so particularly in the realms of phantom scratching. So I'm going to let you just come in here because this is very much your baby.
Well, we have a neuropathic pain complex called canine Chiari and syringomyelia. And dogs with canine Chiari have behaviours that suggest head pain. So they will rub the head, a bit like your French bulldog there, and maybe scratch at the back of their head. And if we speak to humans with Chiari malformation, we know that they get head pain, especially at the back of the head. However, in syringomyelia, you can have damage to the scratch area of the spinal cord, which is the mid-cervical spinal cord. And this can give a phenomenon called phantom scratching. And I just wanted to make the point that this is not neuropathic pain, but it does share some features. It's a maladaptive scratch reflex due to that damage. And so you can tell when they have phantom scratching because you can rub the dermatome, the area of skin that's associated with the spinal cord that's damaged, and that will elicit this sort of scratching action, which is very reflexic. So they kind of make this breeders will often refer to it as playing the air guitar, and they don't tend to make skin contact, and they also twist their head towards the scratching side, as you can see in this dog. You will also see that with emotional arousal, and this dog's been taken for a walk, their neck collar that's stimulating it. One of the important things to remember, though, is that because they have this damage to their spinal cord, they can have phantom scratching and neuropathic pain. In fact, that's much more common. So they will often have vocalizations, behaviors suggesting head pain. They might have hyperesthesia, which is increased sensitivity to a normal level of stimulation. For example, you put your hands on this dog's necks and they jump more than you would think they would. And they may have allodynia, and that's pain from a stimulus that's not normally painful. So often when you touch these dogs on their paw, they will react to that more than you would actually expect. So this is an example where you can have two sort of different phenomenons that are similar but not quite the same. And so I was going to ask you further, Sarah, about what sort of behavioural presentations that you see with neuropathic pain.
So when we think about changes in behaviour, we can think about the fact that neuropathic pain can lead to some resistance to movement. So where there's a more of a physical impact of this neuropathic pain. And that can lead to posture changes. You can see here in this photograph, this kyphotic posture related to being in discomfort may cause gait changes. You may see abnormal placement of limbs. And sometimes we get other changes as well that are more this physical association with neuropathic pain, maybe things like panting. And then in this video, we can see that we can get quite a range of responses that are actually suggesting that this dog is quite distressed. So a little bit of panting, some gulping, some just general agitation, animal unable to settle. So we can see these behaviours which are very much related to the physical impact of the discomfort or the pain that's coming in this neuropathic case. But we also have a situation where it can be slightly less obvious than that. So some of these alterations that we get in sensation, and then they change their posture or their gait because of the impact of that sensation, that can actually exacerbate other emotions, such as fear, anxiety. Now, we'll talk about this a little bit more later, but fear, anxiety, and pain are actually related to each other in an emotional sense. They're part of the same emotional system, if you like. But when you're in that state of pain, you've got that slightly abnormal sensation, it can make you more worried, particularly if there's a perception that you're unstable. So if you don't trust your body to carry you, then that can make you very anxious. And that can be exacerbated in many of our patients by the sorts of floors or surfaces that they are being expected to move on. So if they already have a situation where they are not really trusting their body because it feels odd, and then they're trying to move on a surface that's slippery and doesn't give them stability, then those things can compound their protective emotional state of being fearful and anxious. And we may get reluctance to walk on those surfaces. Maybe they don't want to go across the conservatory, which has got a really slippery floor, and that's the only way they can get out to the garden in order to relieve themselves and go to the toilet. And so we may actually get a presentation that this dog is house toiling. The reason is that it can't actually get across that piece of floor to access the garden because of the pain and feeling unstable. So we can certainly get these slightly more complex relationships between the pain and the behavioural presentation. The other thing that can happen, because again of this abnormal sensation, is that these dogs can be quite reluctant to be handled, and they can be quite reactive when people even disturb them where there's a potential that they're going to be handled. So if they anticipate being moved, or if they need to move in order to gain access to something else, so maybe it's tea time and they want to be fed, but actually to be fed they're going to have to move themselves to get to where they need to be. That could trigger a behavioural response through the emotion of being fearful and anxious about that process of being moved, moving, or being handled. And when these sorts of interactions happen, a repulsion response is probably the one that's the most problematic from the caregiver's perspective. So repelling behaviours are, in the Heath model, which we'll talk about later, we describe behaviours that are designed to push something away, to increase distance from it. We call them repulsion behaviours. So it might be a growl or a grumble, or it may be a snap. But we need to remember that that's not the only way in which an individual can protect themselves. So sometimes protection comes through avoidance. So it's moving away from the potential of being handled or disturbed. But also, dogs particularly, dogs are socially obligate creatures. They like to retain social contact. So growling at someone is likely to make them go away, and me cowering and moving away from them means I can't get the benefit of interacting with that person either. So sometimes we go into these different behavioural responses of inhibition, which is a sort of shut down physical response, but the sensory system is really busy. You can see the dog here, you can see it staring, you can see it as this is a video rather than a still. You'd be able to see that nose moving, gathering olfactory information, the ears are moving to get auditory information. They're finding out as much as possible about this environment that they're in to try to mitigate the potential for there to be pain if they are handled or disturbed. And because they're sociable creatures, dogs may sometimes, instead of using this passive way of gathering information, they may actually want to gather that information more actively by interacting with the person, but they interact in ways that help them to get information from the person. Now, these sometimes can get a bit misinterpreted. We can understand this licking as being like kissing someone. So we can look at it and see it and think, oh, they're really happy and they're engaging and they're showing affection, when actually the individual is just trying to gather information, trying to find out whether or not this is going to be a difficult situation. So it's a protective mechanism that they're using. So we can see that it might be direct because of the physical discomfort. It might be because of an anticipation that being handled or disturbed is going to cause that discomfort. And then we have another way in which these emotions can lead to behavioural responses that are designed to resolve the situation. So they try grumbling or moving away or inhibiting or appeasing, but often those behaviours can't resolve that neuropathic pain. We need to resolve it in other ways, which we'll talk about, and Claire, you'll talk about that in more detail later. But if this animal perceives that they can't resolve this discomfort, that can lead to another emotion, an emotion called frustration. Now, frustration is triggered through failure. It's triggered whenever we're unable to do something that we want to do, when we're unable to achieve our aim. And the thing that happens with frustration is that it has a really important impact on the behaviour of the individual in three main ways. So it increases the speed, it increases the intensity, and it makes that behavioural response more likely to be confrontational in nature. And the impact of that, of course, can be that because they are more confrontational and they do it faster and with more intensity, we may actually find that in this situation, we end up with more risk to the caregiver. They're trying to handle or move the animal, or the vet when we're trying to interact with them, but maybe also more risk to other animals in the household who are approaching the individual, maybe with pleasant intentions of wanting to play with them or rest with them, but that can trigger a perception in the part of the patient where they feel they can't resolve this situation. They've tried using communication and body language to say, I'm uncomfortable, and then they get frustrated. So frustration can be a really important part of this issue.
So, Sarah, are there other ways that pain can affect behaviour other than a direct relationship between the pain and the animal trying to protect themselves, for example, by not moving?
Yeah, absolutely. So if we think about pain, emotion of pain, there are two aspects to this which can influence the behavioural output. So first of all, the valence of the pain. So pain is part of the fear-anxiety system. And I said that earlier. And in Panksepp's model, so Jack Panksepp was an Estonian biologist who did a lot of work looking at the emotions that drive behavioural responses in both human animals and non-human animals. And he talks about pain as being part of the fear-anxiety system. And that can be a real problem when we're trying to diagnose, something we're going to talk about later. But often these animals can show behaviours that are very difficult to distinguish whether it's coming from fear-anxiety or whether it's coming from pain, because they're related to each other. They're both protective. The Heath model of emotional health, we talk about protective rather than negative emotions. So Panksepp uses the words positive and negative. He's absolutely right, because he's using them in relation to positive, meaning you add something, the negative meaning you take something away. But actually, the negative word in the English language is actually quite loaded. We say the word negative and people tend to think bad. It's really important to remember, as Claire, you've just pointed out, that you needed to get your foot off that tack, otherwise you would have been in more damage. So it wasn't a bad thing that you felt that pain. It's not an unwanted emotion. It's actually a protective emotion. And so that's why we use that word in the Heath model to tell us more about the way in which the emotion is aiming to alter that individual's survival. Of course, there are engaging emotions as well, which increase your survival by gaining access with something like food or shelter. And you gave that lovely example of dental pain, where these two types of emotion might be in some conflict. And then it's the one that's the predominant one, that's the one that's going to lead to the behavioural output. So we talked before about behavioural responses either increasing distance from and decreasing interaction with a trigger, or increasing availability of information about the trigger. And so these behaviours I just talked about in relation to the physical perception of pain will also be seen in relation to fear anxiety, that other protective emotional state. And so that can make the diagnostic process quite difficult. So how does pain actually impact on emotional health and thereby influence behaviour other than this direct level? Well, one of them is the fact that pain can impact emotional stability. So I'm going to talk a little bit about the Heath model in terms of 3 components of emotional health, because the aim is to maintain emotional stability, to have emotion that can be coped with, if you like. So we have the capacity for emotion, and in this model, we liken that to a sink. And then we have the input of emotion. I just talked about this difference in valence. So when we're talking about pain, we're talking about this red tap, the hot tap, the protective emotion. But remember, we've got these other emotions that are happening as well, because emotional health is very dynamic. So we're going to have engaging emotions like desire seeking to have food, social play, to play with your fellow members of your species. And then this emotional conflict potential of more than one emotion at the same time, with that poor animal that has dental pain, where the blue tap, the cold tap, is saying eat the food, and the red tap, the pain tap's going protect yourself. And then we need to have that conflict between those types of emotion. And then we have drainage. How do we get rid of emotion once it's served its purpose? So emotional arousal is the result of the balance between those 3. If you've got a good balance, then you can maintain a low level of arousal. We represent that by the level of emotion in the sink, and the aim is for that to always be at its minimum. So when we think about an individual who's in pain, we know that pain is the red tap, it's a protective emotion. I've just also said that it's accompanied often by other emotions that are protective. So fear, anxiety, frustration, they are likely to be seen, particularly when we're in a situation of chronic or maladaptive pain, when it's not resolving. Then that increases that protective input. It increases the amount of water coming in from that tap. And that impact of that increased protective emotion is going to be very variable between individuals, because it's going to depend on other things. You've turned the tap up, that's important, but is there any other factor of this individual that could mean that that dog is more likely to go on to have problems? So maybe it's got a small sink, maybe its emotional capacity is not actually very high, and therefore if we turn that tap up, we're more likely to cause a flood. It may be that there's other emotional input. It could be coming from the hot tap through fear, anxiety unrelated to the pain. It might be frightened of traffic, frightened of people, or it may be coming from the engaging tap, the blue tap. So it may actually be that this dog's having a lot of emotional input, but it's fun. I'm playing with a ball, or I'm playing with my mate. But that's going to increase input and put more strain on the capacity of this individual. And then if the emotional drainage is not up to speed, then that could also mean that we're at more risk of flooding. So high emotional input will increase the potential for that protective element of your pain to have more noticeable effects. So if they've got an emotional disorder already, they've got an anxiety disorder, and then they develop neuropathic pain, or they've got some other physical illness present that's creating discomfort, or maybe changing their ability to cope with their emotion, or maybe they're just having a lot of fun, so someone's playing with them, or maybe they're in a situation where there are fireworks going off and they're frightened of noises. If all of these things are happening, then there's a potential that there'll be a variation in the reported impact of the pain at those times. This is actually one of your cases, isn't it, Claire? This is Charlie, who you saw, who had a problem with thunderstorms, but his situation of his pain from his Chiari malformation and syndromyelia, so he had that pain, but when there were thunderstorms and his emotional input was increased because he was frightened of the thunder, then it exacerbated how much he expressed that pain and how he coped with his pain medications. So we can have this input, this variation on the reported impact of pain, and then the other way around. So if we've got high emotional residue already, that can increase the potential for other emotional inputs to create greater behavioural change. So if that sink is already full of pain, so pain is the main emotion that's filling up the sink, and then we start another input, for example, we increase noise-related fear, or we have social anxiety, or maybe we're a little bit worried about a resource, then we're going to increase that level even further and potentially cause a flood. So this little video here.
You resource got in.
You can hear the caregiver there say, are you resource guarding? You can see the bed here. He's worried about this bed. It may well be that his behaviour over enjoying his bed and feeling that his bed is potentially under danger is exacerbated by the fact that he's in pain. Engaging inputs can also, though, increase that flooding. So we can get variation in the reported impact of the emotional challenge from other sources because they're in pain. So it works in both directions. So how emotion can impact on these responses, how behavioural responses can be changed by emotion.
I was wondering whether you'd be able to help me with one of my cases, explain some of these things in a little bit more detail. Also, wonder if you can explain more about the cognitive health aspects of pain.
Okay, so let's actually have the discussion. I'm sorry, that's my mistake there, not advancing quickly enough. There you go. You can tell that this is genuine, this presentation. We haven't fudged it. So here, sorry, Claire, you wanted me to give advice about this case and I forgot to advance the slide. So over to you again to talk about the case.
Yes, sorry. This is one of my cases that I've recently been asked about, and it's a little Cavalier King Charles Spaniel, and it was obtained from what was thought to be a reputable breeder. The owner did her homework, she thought, and it came from a litter of 9 puppies. And she saw mum, and everything seemed to be okay. The notes from the vet suggested a pretty normal puppy, and they vaccinated it and did all the usual puppy things. And when they saw the dog in November, a couple of months later, then the caregiver reported that basic training was going really well. The local vet then saw it again in January, and this is when it started showing signs that in hindsight are pretty typical for Chiari pain. So vocalization when jumping, so a sort of valsalva mimic, which means a sudden change in thoracic pressure that you get when you jump, results in pain in these dogs. Occasionally when being touched, so increased sensitivity, hyperesthesia, certainly, possibly even allodynia, and also a vocalization when he was on walks. It obviously went to the vet, and the vet found that the dog was hyperesthetic in the neck region. Because of the breed, they referred to a neurologist, and in between that time, the dog developed a real problem with resource guarding. The dog then had an MRI scan investigation in February this year, and it identified this canine Chiari and syringomyelia. And I don't have the pointer on my side, but perhaps Sarah is able to point to the spinal cord area. Yep, there we go. And then right in the middle there, we have a area of fluid-filled space, which is syringomyelia. We've got a line going through there. It's quite a small syrinx in this dog. It's fairly symmetrical. It's probably not the syrinx that's causing the signs. We haven't got the images of the brain there, but there's certainly an indentation of the cerebellum with is the ligament that goes between the back of the skull and the atlas. It should be horizontal. It's not in that dog, it's vertical. So we know there's a very short back to the skull, and I'm sure we would see other changes if we had the whole MRI scan to be able to diagnose canine Chiari. So this is what was diagnosed, and the dog was started on, again, what in hindsight seems to be quite a low dose of gabapentin. Normally we start at 10 milligrams per kilogram. The vet also gave some metacam, and there was some improvement, but then the behavioural problems escalated.
How do you know?
It's a couple of interesting things here. I hope you're all noting the slippy slidey floor that we've just talked about earlier, that sort of surface can really exacerbate the fear anxiety component of this issue.
From what I know about this case, I think they're trying to move the dog away. I think they're having trouble actually walking across their kitchen because he is guarding the area.
Yes, you can see that that resource of space being worried. So again, if we think about the link between the emotion and the responses, maybe that there is some direct response here because he's uncomfortable and people coming towards him might mean he's going to be handled, as we talked about. We've then got the slippy slidey floor and the feeling of being unsafe and unsure about his footing. So that's going to make him more fearful and anxious. Then they bring some food in, which is quite a good way of doing this. So they're going to use food to turn on the cold tap and get more of that engaging emotion and therefore move him without touching him. Very wise. So that's what we do want to do. We don't want to be moving him by directly handling him. So we're going to use it passively, but we're going to be a little bit careful of when we're using that food is that we don't turn that cold tap on too high, because this dog's not got much space left in his emotional sink. And if we do too much in the engaging department, then we actually may push him even closer to his threshold. So I would be using that food as they are doing, maybe putting it more passively, maybe also because it's a slippy slidey floor, maybe just placing it rather than dropping it because it's bouncing. As it's bouncing, it increases that excitement, if you like, the more, oh, where's the piece of food? And then it's going to encourage more movement. That could trigger more pain. So we could use just a very quiet food trail, maybe a scatter of food, so that it's not so reliant on the caregiver as well. So just a spreading out a bigger scatter of food rather than dropping individual pieces.
No. In your crate. In your crate. Coachy, back off. Look, in you go.
I'd love for you to interpret this one for me, Sarah, because I noticed that the caregiver has a pillow when they're approaching the dog. They're obviously worried that something's going to happen, and but they do successfully move the dog into the crate, which I presume they were. And again, I think that the dog is blocking the exit there.
Yeah, absolutely. This is fascinating behaviour, isn't it? And this little dog. And you can see, again, it highlights really nicely what we just talked about this emotional connection, because there's an anticipation here. The caregiver's not doing anything. The caregiver's not actually caused any sort of threat. But you talked earlier about the memory of discomfort and pain. And so this poor little chap, if he's got an association with that memory of that pain, then he's going to be anticipating that you trying to move me is going to be painful, could make it difficult for me. Therefore, he's becoming protective in advance. And as you say, there's the caregiver also showing protective behaviour, because they've obviously had a bad situation before where maybe they've been bitten or challenged by their dog, and therefore they are reacting with fear and anxiety. They're bringing in their pillow. I think the pillow there is being used mainly protectively for the human. They're not, I don't think they're trying to use it to move the dog. I think they're trying to use it to protect themselves. But we've got to remember that the poor little dog is going to see this large item looming over it and coming towards it, and have a perception that it may actually be something threatening to them. So yeah, having the enormity of the pillow, if you like, and probably the fact that the way it moves may exacerbate that fear and anxiety. And again, then trying to get him into the cage. And he's going into the cage more because he's trying to avoid something he doesn't want, rather than going into the cage to get something he does want. And we can think about that when we're trying to change these behavioural responses, to think about trying to get them to move in a different direction because that's what they want, because that's the more pleasurable outcome, rather than they're trying to get away from the thing they don't want. So yeah, really lovely case of very obviously a physical health condition, but also with an emotional component to it. And then there's the cognition, the memory, the learning as well. So beautiful example of the triad of health that needs to be considered in these cases.
Thank you very much. We're going to talk more about managing those cases, but before that, could you tell me more about the cognitive aspects of the pain?
Yeah, so cognition is the third part of the health triad, and we know that there's different ways in which associations between pain and behaviour can develop through learning. So pain can have a cognitive impact, and because it's an emotion, it can be associated with other stimuli through a process that we call classical conditioning. So in classical conditioning, you've got a stimulus that's leading to an emotional response, in this case, a pain-inducing stimulus that's leading to the pain response. And then it's occurring in a certain context. So maybe it's happening when the individual's at the vet's, or maybe it happens when the individual's on a walk. And that ties nicely into the case we just talked about, where you said that those vocalizations occurred when he was handled, but also when this little chap went for a walk. So the potential for that pain to be associated with a particular context. And if that happens again and again, then we get what's called classical, or sometimes referred to as Pavlovian conditioning. And you may be remembering from school days Pavlov's dogs, when they were in the laboratory and food made them salivate, but then the metronome tone was sounding in the laboratory. And because that happened, that sound of the metronome happened at the same time as the delivery of the food, that eventually the metronome could make those individuals start to salivate even when there was no food. And the same way, that context of a veterinary practice or going for a walk through classical or Pavlovian conditioning can be associated with the pain, such that just going for a walk can create a pain emotional response, even though there is no physical sensation, maybe because we've got our analgesic pain relief really right and we've got that pain really well under control. But if this classical conditioning has already occurred, then we may still get those contextual associations. And then there's another form of learning. So this form of learning is called operant or instrumental conditioning. Now, this type of learning increases or decreases the probability that a behavior will happen again in the future. And the way it does it is that the cue leads to an action, the animal responds, does something, and then there's what we call a consequence from that action. So the behavior has a consequence for the individual, which then alters the probability of that action happening again. So if we give this individual who has discomfort and pain a verbal cue to sit, and this dog has learned that through previous associative learning, that means I should lower my back end to the floor and adopt a sit posture. So because the dog has learned that, he complies with that, he responds to that cue and goes into a sit posture. But if that leads to maybe pain, maybe neuropathic pain because there's some intervertebral disc disease, for example, then that pain is a consequence of that action and will decrease the probability that that animal will adopt a sit posture again when it hears that verbal cue sit. And that can lead to some confusion because we can think this animal's now becoming stubborn or disobedient or difficult, because I'm sure he knows the word sit. I can't understand why he's not going into that posture because he knows what that means. But if there's some discomfort, then that could be affecting that behavior by operant conditioning. So those are two learning aspects. But I want to go back to something you said earlier, Claire. You talked about memory. You were talking about the amygdala and the hippocampus and how they're involved in memory formation associated with pain. So we can have a direct impact through the memory of the pain, leading to this anticipatory behavioural response in the future. And examples of that might be a dog that avoids the context you mentioned earlier. I mean, they're not going to want to go to the vets anymore. She's like, you're not going to want to walk barefoot across that stage anymore. So we're going to avoid that context in the future. But also, we can have an indirect impact of that protective emotional state on memory. Because we know that when you're in a protective emotional bias, what that basically means is that you've got more red tap than blue tap coming into your emotional sink. That favours the formation of pessimistic memory. You're more likely to remember those things that could potentially cause you harm. That's very biologically adaptive. If you have had a protective emotional response, therefore you're going to think about and remember the things that could potentially harm you. And that can increase the level of fear anxiety in relation to other triggers. So Charlie, who we mentioned earlier, your case with the thunderstorms, that memory of the thunderstorm is going to be a more pessimistic memory, an enhanced memory of that, which means his next response to thunderstorms may actually be worse. And then finally, in cognition, pain also can influence memory through its impact on sleep quality. So sleep is incredibly important in emotional regulation, but also it's important in adapting your brain and the way that you deal with these protective experiences through something called amygdala adaptation. I'm going to mention that later, but also through what we call memory stripping. So emotions, you talked earlier, Claire, about this. When you were talking about the amygdala, you said how important it is that we form a memory of that emotion. We need to know that that was an unpleasant sensation, but actually you don't want to hold on to the intensity of that memory of the emotion. You want to slightly lessen the emotional intensity, but keep the memory of the event. So not necessarily a pain example, but I think this is quite a nice example for us humans to relate to. If I'm walking along a road and I absent-mindedly step out into the road and nearly get hit by a car, then I'm going to have an emotional memory of stepping into the road absent-mindedly because it created, hopefully not real pain, because I hope you don't get hit by the car, but certainly an anticipation of being threatened by the car that was coming towards me. So I'm going to have this really emotional memory of being terrified when I stepped absent-mindedly into the pavement, off the pavement and into the road. But if I want to be able to survive, I don't want to have that intensity now every time I walk down a pavement. I still want to remember that absent-mindedly stepping into a road is a bad idea. So I want to have the memory, but I don't want to have that terror of being so frightened, but eventually I can't walk down the pavement at all. So this emotional memory stripping happens during REM sleep. And so therefore, if pain is affecting the quality of sleep, then that can also influence the emotion or the memory as well. So again, another way in which there is a cognitive impact. We've looked at emotion, we've looked at cognition. Now I want to move on with your beautiful diagram here, Claire, to the idea of how we actually diagnose neuropathic pain. So can you talk us through this process as to how we get to the point of actually knowing that we have a situation of neuropathic pain?
We should clarify that a little bit, because actually neuropathic pain isn't a diagnosis in itself. It's a bit like anemia in that sense. It's a clinical observation. And the question is why? Why is there neuropathic pain, not just that there is neuropathic pain? And I put these sort of 4 prongs here really because some of these things can be easily ticked and you get the diagnosis, but sometimes it can be a little bit more challenging, especially if you don't have access to the diagnostic tests. So I'd say the most important thing actually is having a history of having that damage. So we have, we say, for example, history of an orthopedic surgery where the sciatic nerve was retracted during the surgery and not dynamically retracted, which means you take the pressure on and off, but retracted during the whole procedure, which is much more likely to give damage. If we have that kind of history, then that is one important key point. If you don't have that kind of history, then you may be able to have diagnostic tests which show the lesion, for example, an MRI scan or neuroelectrophysiology, which is a way of testing nerve function and muscles to show that there is a damage to the nerve. But another important aspect of neuropathic pain diagnosis is evidence of abnormal sensation, either decreased or increased sensitivity to touch. And you may be saying, Sarah, what do you mean decreased sensitivity to touch? Surely that would suggest they don't have neuropathic pain. Well, that's because in many animals that have neuropathic pain due to a peripheral nerve injury, they may actually also have a degree of numbness or hyperalgesia or even analgesia in some areas. So, for example, a cat with that or dog with a sciatic nerve lesion may actually have reduced sensation when you to touch. They may have reduced reaction, but they have evidence of experiencing abnormal sensations, which we call paresthesia or dysesthesia. And you may say, well, how do we know they are doing that? Well, they may be mutilating that area or have other ways in which they're protective of that area. But in some instances, it can be quite challenging to make that diagnosis. And I do think that there is an argument, especially in general practice, to say maybe there is an option for a treatment trial. So if you have a suspicion, maybe there is some suspicious history, if you give a trial of drugs that affect neuropathic pain or nociplastic pain, and they have a strong response to that, then it's an argument that that's a problem. You may be arguing, actually, Sarah, with me. You may say, well, some of the drugs that you use, Claire, actually affect cognition as well, actually might affect fear and anxiety. You may give me an example of pregabalin. And I would say, yeah, that's true, Sarah, but in a real world, don't we want to find a treatment that just makes the animal happier? So yes, maybe if I am treating its fear and anxiety, then and not its neuropathic pain, then I don't have an accurate diagnosis, but I do have some sort of treatment.
I think you wanted to just mention the Chiari check, which we can do quickly, and then I'll just look at some of the ways in which we can approach those emotional sides before we finish with how we manage these problems.
Yeah, I just wanted to highlight this. Chiari pain is quite difficult to diagnose, and we do have a questionnaire checklist that can help you in that respect.
Okay, so in terms of the emotional and cognitive aspects, we can just summarise the fact that we need to always think about the fact that physical, emotional and cognitive health are factors that coexist. It's not one or the other. So to determine the relative contribution from emotion, we're going to think about whether we've got those behavioural responses we talked about and that body language that suggests protective emotion. We're also going to think about whether there's any high level of emotional arousal. Is the sink already full? And there's a little overflow hole at the top of the sink where displacement of water happens to stop a flood. And we have the same with behavioural responses. So we can get responses like yawning or lip smacking or shaking, scratching and self-chewing can also happen here. That could be difficult with neuropathic pain cases because we just said that could be coming directly from the pain as well. But These are indications that the sink might be full. And then the other thing we think about is there any evidence that the drainage is compromised? In dogs, they drain out through their chewing. So if we've got any of those triggers, then that pushes us towards thinking there could be an emotional component. So we're going to wrap up on management then, Claire, management of neuropathic and nociplastic pain. And we'll just give a quick run through this because we're going to try and wrap.
I would say that this is quite a complicated subject, and I have quite a few supporting videos which you can access through that YouTube, both on canine Chiari and neuropathic pain. But I thought I'd just very briefly go through a couple of drugs which may be more applicable. And so otherwise, the drugs can be accessed by dedicated videos. The first one I wanted to really sort of mention was the monoclonal antibodies that target NGF. Now, of course, these drugs licensed for treating, if we go back one, licensed for treating osteoarthritis, but what people may not realize is that actually their site of action is the dorsal nerve root ganglion, and they interfere with the nerve growth factor, which makes in a lot of changes in that dorsal nerve root ganglion, resulting in overexpression of many compounds. And so actually, though it's not licensed for that use, theoretically, these drugs could be used for targeting peripheral, not central, because the dorsal nerve root ganglion is peripheral, but peripheral neuropathic pain. The next drug I wanted to mention is really affecting the spinal cord, and this little star here is meant to represent the superficial dorsal horn, which in the little bit of spinal cord that you've got there is a tiny bit of purple right on the over edge. And when the nerve signal comes in from either the C fibers or the alpha delta fibers, it releases a neurotransmitter called glutamate and also a substance called substance P. When that keeps on firing, which Sarah's going to do by advancing the slide again. So it's got firing, and then eventually when it fires, that magnesium block comes off. And then that allows opening of something called the NMDA receptor. And that NMDA receptor is important in something called wind-up. And so what that does is it causes a lot of changes on the postsynaptic membrane. We get more receptors, we get release of nitric oxide, and we get release of more transmitter. And what that basically means is that that is in a wound-up state. And this is one of the changes that result in something called wind up and then central hypersensitivity. So if we can stop that process, that would be great. And so one of the drugs that we can use is in the next slide. And so we have a release of that magnesium block and release of that glutamate that's going to bind to that receptor. Then if we give a drug which stops that glutamate, the gabapentinoids, things like gabapentin and pregabalin, we can prevent that glutamate release and slow down that wind up. Now we can combine that with a drug which actually can reduce that NMDA receptor. So sometimes we will use periodic or one-off ketamine. That's ketamine given by a single injection. And so in this, what ketamine does is if we see that the glutamate is being released again there from there, and we're getting action potentials coming on now. Yep, there's the action potential. And then after that's had enough, we get the magnesium block going away. And then we get glutamate binding to that NMDA receptor. However, if we give ketamine, there it will actually bind to that glutamate binding site and block the receptor. The other drug that we can use is something else that is blocking that NMDA receptor. Slightly different way. I think these molecules are really cool as memantidine and amantadine. So when the magnesium block comes off, so we have the glutamate coming off, the magnesium block is going away like that. And what these little molecules do is they actually act as a bridge, just like the magnesium. So you can see they've got really 3D structures and they block that NMDA receptor. So in many instances, we can use these drugs in combination, a polypharmacy, to affect our wind-up, our central sensitization, and this nociplastic and neuropathic pain. In addition to your cognitive and behavioral approaches, Sarah, how do you address those?
Yeah, so finally, we're going to address the emotional and cognitive components. So when the behaviour is directly related to the physical component of pain, then of course we need to do exactly what you've just talked about, use appropriate medication, maybe surgery in some cases. But when the behaviour is related to emotional burden, we also need to think about altering that emotional bias. So that will modify how the individual perceives their pain. Increasing their engaging bias, for example, through play, as we can see here, increasing triggers for that engaging emotion, as well as increasing the perception that they can cope. Remember, we talked about frustration. So this little Daxi here being allowed to dictate where he lies and the person being passive with him and not interfering and not trying to touch him all the time. Decreasing any other triggers as well for protective emotion are going to be important, as well as using cognitive approaches. So here we have the individual being taught to touch as a cue for being handled, so they have some control over that interaction. And then also think about improving emotional drainage through opportunities for chewing, opportunities for sleeping that we discussed earlier, those really important drainage behaviours. And if the behaviour is related to memory, then of course we're going to actually want to form some new behavioural associations in those contexts where there's been pain previously. So I'm going to hand over to you, Claire, to wrap up with our conclusions from our little chat this morning. Over to you.
So, in conclusion, well, pain is normal. We need it to survive. It demands a behavioural response to protect the animal, and a painful experience results in a memory, so the animal can learn to avoid it. However, you can get these abnormal pain states, which we call nociplastic, when it's related to things like osteoarthritis, and neuropathic, where it's related to damage to the central or peripheral nervous system. And these do not benefit the animal and are a disease in themselves. And they impact and are impacted by cognition and emotion. So you need to consider management strategies that will reduce these central sensitization, like the drugs, and you need to consider management strategies to address the emotional and the cognitive components. Thank you very much. Thanks for listening to us.
Hello, my lovelies. Now, that was a whirlwind. The honest truth is, Sarah and Claire were given 50 minutes to do a talk. It came in at 1 hour 20. So there was a lot of condensing of that recording. Now, the amazing Sarah's been backstage answering your questions as we went along. We are not allowing her to do any more. We need to crack on with the next talk. But Claire and, well, Sarah definitely, hopefully Claire, will be joining us on Canine Arthritis Management, 4th of June. Put it in your diary now. It'll be 7 p.m. British time. So please do join us there with the questions. I'd like to say thank you, Sarah.
Some questions. I've done my best to get through all of them. Anything I haven't got through, we'll take out, and Claire and I will deal with on the 4th.
Perfect. Right, come on, guys, crack on. Get to the next session. See you later.
And I, for one, can't wait to hear what they've got to say, because I think it's going to be really applicable to the dogs that we're seeing, and how we can sort of benefit them when they've got chronic pain conditions and enrich them without necessarily using exercise and things that we traditionally use. So just a little bit of housekeeping. Remember that we will try and do a Q&A at the end, so please put your questions in the Q&A box. The chat box is better for sort of general commentary and comments, and we'll try and keep a track of both of them. We might not get through all of your questions, but please don't hesitate to put them in the box, because we can put them to the speakers afterwards, and it also helps us to generate future content for canine arthritis management. So I'll just introduce our speakers today. So Amber Batson is a vet with a special interest in behaviour, offering affordable first opinion services with her company Understand Animals. And she's just been telling us about how she lectures in behaviour all around the world. So we're really lucky to have her speaking with us today. Kirsty is an ABTC dog trainer and the founder of Dog Knows, a multi-sensory scenting playground for dogs. So they're teaming up today to help us understand what role the environment plays in the management of chronic pain and how we can exploit it to good use. So I'll hand over to both of you.
Thank you, Jade. Yeah, it's been a delight for both of us to have been invited to speak today. So actually, pain perception and environmental influence is a big topic. Our main focus for today is going to be on the role of environmental enrichment, as Jade just started to talk about, because obviously there are other aspects of the environment which will impact on the chronic pain experience. As an example, on the opening day on Friday, as one of the bite sizes, I did a presentation on sleep. And so there's lots of elements of the environment which might impact on the dog's experience of their own pain. But our intention today is to explore what enrichment can bring to the pain experience for the dog. So what is it to enrich? We define enrichment as improving the quality of the animal's environment so they have a greater choice of activity and increased control over their spatial, social, and internal environment. Actually, when we look at the science of enrichment, and environment enrichment has been very well studied, particularly in laboratory animals, so we understand the internal physiological changes that might occur, then we do talk specifically about enrichment creating biological change. So enrichment isn't just about the sensory experience for the dog, a pure feel-good factor. It is actually linked to improved biological functioning. And I'm going to talk a little bit about the elements of chronic pain in just a moment. So I've just talked about the concept of scientific research and the sorts of studies that have looked at the values of environmental enrichment when it's undertaken in a laboratory setting, so that we can actually then study, well, what biological processes have and haven't changed because of these experiences, what perhaps behavioural changes have occurred because or not of these experiences, what emotional changes, temperament orientated changes may we see or not see as a result of these experiences. They are quite specific, and when we're looking at the positives that can come out of environmental enrichment, so perhaps a decreased pain perception, if we think about that as a focus for this presentation, but in other aspects it could be improved self-confidence, it could be a reduction in fear and anxiety-based tendencies, then what we see is those research opportunities, that what is environmental enrichment within that group of animals who've been studied tends to have involved things like structural elements. So giving a bigger housing space and then filling that housing space with species-specific opportunities. So when we're talking about laboratory rodents, as an example, there will be increased platforms and tunnels and things to explore. These types of scientific projects often include increased social opportunities. So instead of being housed on your own or being housed with just one individual, you're now living in a bigger space with maybe 3 or 4 other individuals. There's often increased housing elements, so increased resting and lying areas, different types of bedding, different textures, etc. And then there may be increased foraging elements. So there may be puzzle toys to locate food. There may be increased chewing and variety of chewing and textures. And the reason why I mention that is because actually the foraging elements is often a smaller component of the scientific research that's been done. It's that increased space, increased exploratory opportunities and increased social opportunities that are normally the ones that are being done when we find significant biological change. Another thing to consider with that scientific research is that we have two groups of animals. So we've got animals who are living in an enriched setting, and we're looking to see what their tendencies tend to be, versus animals who are living in a non-enriched, quite barren environment. So actually, we need to also consider how much is enrichment going to be effective if we only offer it for maybe 5 minutes twice a week. Because the scientific studies that are finding the positive benefits are immersing the animal in the enriched environment. So they're living the life rather than it just being what I call a pleasant transient period. You know, if we've got an animal who's actually living in quite a barren environment, they're being crated for long periods of time, kennelled or tethered for long periods of time, living in, you know, fair periods of social isolation, to then maybe add in opportunities, maybe 5 minutes twice a week, it's still a positive for that animal. I'm definitely not trying to say it isn't, but it might not bring us the same biological positive found in the research. So this is really just to highlight all the way through the presentation. You're going to find that there are specific references, and this is so that if you want to, you can go away and actually find the science that I'm referring to. So there's a reference list at the end of the presentation, which will be in the PDF, which you can have a look at. So a piece of work that was done by Chimera in 2022 is a fairly good review, actually, of the physiological pathways that may change with good quality environmental enrichment in specific relation to chronic pain. And you can see it mentions here alterations in the environment are favouring individual well-being, and they may decrease or prevent chronic pain through epigenetic alterations. Also because they may impact on chronic pain-related symptoms, what we might refer to as emotional comorbidities. We can see increased anxiety tendencies, increased fear or frustration tendencies in individuals with chronic pain, and perhaps the environmental enrichment helps the individual cope with those emotional tendencies as well. This specific piece of research is a very good review. It's definitely worth reading if you want to understand the science a bit better. Is really focused more towards neuropathic pain. And I know we've just had a wonderful presentation, I have no doubt, from Sarah Heath and Claire Rusbridge about neuropathic pain. But also research has looked at visceral pain, and research has looked at musculoskeletal pain in relation to environmental enrichment. So, you know, we do have a variety of pain types that we know can benefit from environmental enrichment. Environmental enrichment can do things like increase sleep quality, impact inflammatory pathways, and can help coping mechanisms for those comorbidities. So it's a multifactorial way of thinking. Type of enrichment matters. So I've just talked a little bit about, you know, what might go on within the environment. An earlier piece of work by Chimera showed that simple enrichment, so something like just adding in a forage toy, didn't have the same benefits as increasing space and exploratory opportunity. We do need to think about what we mean about enrichment. And then last year, we had a specific piece of research that looked at chronic pain, maybe we might say acute pain, or the pain experience in dogs, and potentially using environmental enrichment to influence that. So in Pennington, these were dogs who've had spinal surgery, and then they were divided into two groups: dogs who recovered from that surgery over the first few days post-operatively in a normal hospital setting versus those who were recovered for those first few days in what they considered an enriched environment. So we do have some research which has started to look at this in dogs. And in this very small, so we probably, you know, we'll call it a pilot study, did find that the dogs who went into the enriched environment post-operatively overall needed less rescue pain medication, and they also ate better within the first 48 hours post-surgery. And it was concluded by the authors that perioperative environmental enrichment methods could be therefore considered and explored more as part of a multimodal approach to pain reduction, analgesia. There would be a question about this, and it's what we're going to be thinking about, is that really enrichment or was that stress reduction, and how do we separate? Mechanism, this particular slide, I'm not going to go through this. This is so you've got a list, a starting list really, of some of the intricacies. If we're interested, probably mostly for the vets amongst us or other people who are working in a very scientific level, to really understand the physiological processes which influence chronic pain and can be influenced by environmental enrichment. So, you know, as an example, whether enrichment can influence the endocannabinoid system, and things like how enrichment affects brain-derived neurotrophic factor and what that might mean. Studies looking at very specific inflammatory pathways and the impact and modulation of inflammatory pathways by environmental enrichment. And perhaps more recently, as we start to delve further into the effects of the microglia, both at a gut level and at a brain level, and that influence on the chronic pain pathway and perception for the individual, we're starting to look at that from an environmental enrichment perspective as well. A quite in-depth review of the influence of the environment on chronic pain. Santana had published this piece of research earlier this year in 2024, which I think is a really good starting point if you really want to consider the whole environmental effect on chronic pain. And within that review piece of work, then we have considerations of environmental enrichment. So what we're thinking then about the practicalities of enrichment and why that might matter to a dog with chronic pain. We're all very familiar with 5 senses of smell, sight, hearing, touch, and taste. And these apply to dogs as much as they do to humans, but of course there may be individual preferences and species-specific preferences. Dogs lead a predominantly olfactory world, but depending on them as individuals, certainly visual plays a very close second, but they do experience their world through the other 3 external senses too. But there are more than 5 senses. Consider there to be 8 senses, so we need to add in perception, that sense of self-movement and body position and posture, which occurs at both conscious and unconscious levels. We have equilibrioception, spatial orientation, coordinating movement with balance, certainly impacting on our acceleration and deceleration within our world, and interoception. How do I feel inside? Do I feel comfortable inside? What's going on with my bladder? What's going on with my hunger? What's going on with my tiredness? What's going on with my temperature? And so they are senses too. So when we think about enrichment, environmental enrichment opportunities will naturally incorporate multiple senses. It would be rare for us to really only focus on one. Even if we lay a scent trail for a dog and they're using their olfactory sense, they are of course using proprioception, equilibrioception, and interoception simultaneously. The value of different sensory experiences will vary on an individual level because some dogs might be more orientated towards a particular sense than others, and might find some senses more easily overwhelming than others, just like we see in humans. Sensory perception is individual, but that may also change within an individual's lifetime. And over this brilliant symposium, we will have been hearing about chronic pain experiences in young dogs as much as in elderly dogs, and where a young dog is in terms of their sensory experience and sensory preferences can be very different to when that dog is much older and perhaps their hearing has reduced or their eyesight has reduced. So we need to think about the individual in front of us to know or to consider what might be best for them.
Types of enrichment often get discussed as fitting into 5 main categories. We can think of social, cognitive, physical, sensory, and food. They are, of course, not mutually exclusive. They overlap. Often what we might be doing cognitively could include food or could include sensory experience. So, but it's useful to us to just think about the individual dog and, oh, okay, what do I want to offer as enrichment? What do I have the ability to offer as enrichment? Is it social? Could it be cognitive? Is it physical? Is it sensory? Is it food-based? When we think about free-ranging dogs, Canis familiaris, living in a free-ranging environment, the main thing that they've been shown to do in their time budgeting, their primary activity is information gathering. But of course, they are also a highly social species. Food acquisition is normally 1 or 2 forays across 24 hours, and they will be going to find their food using their nose and their eyes and maybe their ears, remembering dogs are primarily scavengers rather than predators, and they often would choose scavenging over predation where they're able to in a free-ranging environment, but they have the ability to do both. So overall, when we think about 2 forays a day, certainly both of them less than an hour, as studies have suggested, then actually we've got 22 other hours of stuff going on, which is about information gathering, social experiences, etc. Interestingly, a study that was done by Hunt in 2023, a pilot study, smallish numbers of dogs, did show that the dogs seem to demonstrate more positive outcomes in relation to social time with other dogs, or what was called playhouse exploration. Playhouse exploration, going into a room where there are different sensory experiences, platforms, toys, tunnels, etc. Whereas they found food enrichment to be the least relaxing in that study. Now, enrichment doesn't have to be relaxing, but again, it depends on what we are trying to achieve. Important that we think about whether enrichment can ever be negative to individuals. It's something as we move more into the practicals in a second, Kirsty and I are going to really dig ourselves into, because enrichment can be overwhelming. You know, we take a smell, it could be olfactorily overwhelming. If we put too many things out for a dog, that could be mind-blowing if they've never really developed the skill set of choice. It can be frustrating, can be scary because, you know, actually that odor's too strong, that sound's too strong, I'm scared of that visual stimulus. And of course, something we must consider with our chronic pain patients, could the enrichment, doing the enrichment itself, be painful for the dog? So if I put a very tasty paste onto a plate and I put that at ground level and the dog's desperate for that tasty paste, but actually lowering their head is increasing their head pain, their ear pain, maybe their neck pain, their back pain. Oh, they're still going to do it, but actually afterwards it could feel sorer. So we must consider the potential negatives within enrichment. And again, these are here sort of for a reference, but we've 2 studies from 2023 which did highlight how certain types of enrichment in certain circumstances could increase things like frustration in the dog. So we want to be careful, and we want to be thinking about that when we make our setups. So enrichment in dogs, what opportunities does it give us? Because obviously we're thinking it can allow the dog to explore. I know we're going to be hearing from Kathy Murphy and Bobby Banbury today. They're going to be talking about resilience. I can almost guarantee they're going to be talking at some point about agency, autonomy, and opportunities and choice, all tied in together. And so opportunities to make choices for yourself, to explore, to decide if you want to gather new information or not, using a variety of senses, which includes the use of the nose, is going to be hopefully a wonderful opportunity to the dog if we're careful with and considered with the setup. We definitely want to think beyond the bowl. We Google environmental enrichment in dogs and we're going to be hit with a large number of products which are about putting food into the dog's environment and making it more cognitively challenging for the dog to acquire the food, that's only one type of enrichment. You know, all of the other senses that we've considered that aren't just about smell and taste would want to be incorporated. So how does the dog coordinate information coming in, their body movements, their goals? We call that sensory motor integration. That's something the dog should be getting the opportunity to consider, particularly for an individual who's got pain somewhere in their body. How does it feel if I do this? Am I safe to do that? Opportunities for genuine choice, freedom to choose the amount of engagement, or perhaps not to choose to engage. And we'll talk about that a little bit more in a moment when we think about, oh gosh, are we luring dogs at times to do something like putting the very tasty paste onto the plate? The dog's desperate for the paste, but maybe they wouldn't choose to have it in that particular location. Does give them opportunities to play, manipulate objects, have those kind of self-directed positive opportunities. And when they're doing many of these things, it gives us the opportunity to observe them, as well as them perhaps being able to practice problem solving, emotional regulation, things that will hopefully help address some of the emotional comorbidities of chronic pain. Definitely from our human perspective as well, if we've set things up well, non-slippery, appropriate choice, then we can think about what is the dog doing? How are they moving their body? Are they moving freely? Are they looking stiff? Are they putting weight on one limb or set of limbs more than the other? Are they choosing to avoid head lowering? When they head lowering, are they lifting up a paw simultaneously to alleviate some tension or pain in the body? So it's a great opportunity if we're willing to sit down and put down our phones and just have a cup of coffee and just watch the dog. What are we learning from that? Great opportunity for us as well. Esty.
Sorry, I have dogs in the room, so I'm muted just in case. So obviously, one of the things that we need to think about when we're setting up these sort of opportunities for dogs is the fact that from the dog's point of view, their perspective is actually quite different to ours. They perceive the world differently because their senses are set up to take different information in. But also from a practical point of view and from a physical point of view, they're several feet lower. You know, their visual perspective of the world is several feet lower than us. And if you ever wonder about, you know, how much this impacts you, go into a place where there's, you know, a certain amount of busyness, so people moving around, but you're not in any danger, and just kneel down. You suddenly feel much more insecure. The world is a very human-centric place, and there are things which are visual from, you know, 1 foot or 2 foot off the floor that aren't visual from 5 foot or 6 foot off the floor. So, for example, in these two pictures, you can see that the only thing that's changed is that the stuffy dog in one is facing away from, in this case, it was the door, and in the other one, it's facing towards the door. Now, from a dog's point of view, going in and that being your first visual kind of impact of that space, that stuffy dog facing towards you would be quite jarring. It's not actually visual from a human point of view. I couldn't see that effect when I was standing up. I only saw that effect from the ground level. Because their vision is set up to capture movement at low light, they also see things that are movement in the environment faster, and it's more impactful than for us. So things which are reflective, so the pattern of light reflecting on shiny surfaces or white surfaces, things like that, can be again much more meaningful and impactful to a dog than it is from a human perspective. So we need to be very careful about those sort of things. The impact of sudden noises, particularly for a dog that maybe has pain ongoing in their bodies, a sudden kind of jump start means all your muscles tense, you have a sudden jolt into all of your joints, this can be really, really off-putting and quite damaging for a dog psychologically and emotionally. So we have to be very careful about offering opportunities that are appropriate for from the dog's point of view. We can very often not realise that there's pain going on. So even if we've diagnosed pain in somewhere in the dog's body, that dog could be experiencing pain in other ways. So particularly if we're, like Amber was saying, if we're using high value, sort of nice, tasty treats, we need to make sure that it's fair for the dog. So offering them in multiple locations, offering them different ways to access those means that they can take the opportunity for the most comfortable, the most comfortable route. This is also going to give us information if we're watching for it, because we can see whether the dog goes, I'm not really keen on having my weight on my back legs and stepping up with my front legs, but actually I'll move up the ramp side or I'll move up to the lower step. And this can give us information about maybe something that hasn't yet been diagnosed to then have a look at in more detail. If we give them those options, it also reduces the chance of frustration. If there's only one way to solve a problem, if there's only one way to access that high value resource, the dog is more motivated to kind of bash away at it, even if it's not very comfortable. We need to think about how they're moving around this sort of space when we're offering these opportunities, just in general, but also what I call the unpacking process. So if we've offered some stuff that can be rummaged and stuff that can be kind of moved around, how is that debris, once it's been unpacked, going to impact then the dog's ability to move around the space? And also, the dog's size, the dog's age, the dog's general mobility will also impact on that. So the less mobile they are, the more stiff they are, the larger turning circle they need to actually maneuver around, then obviously the larger walkways and the bigger gap in between these sort of nice opportunities, these sensory opportunities that we're offering needs to be. And I'll hand back to Amber for that.
Yeah, so just thinking about, so this dog wants to engage with this particular activity. We've got some different smells in these mesh bags hanging at head height, because this is a dog, an older dog with neck, back and hip and stifle pain. Is this a positive opportunity? But what we can see here is that he becomes particularly wanting to engage with this odor on the right. And can you see how he's waving his head back, left and right? And if you watch his body, you'll see how that's impacting on his spine and his muscles. So he's actually rocking his weight backwards and forwards repeatedly. And actually, this could be frustrating to him. It could actually also become uncomfortable for him. And although he's not choosing to disengage, it may well be because that odor is of such great interest that he's lured in. So what could we do differently is if we'd have just tied those bags much shorter, much tighter up onto the rope, they wouldn't be swinging backwards and forwards. And if they weren't swinging and then he could actually push his nose against the mesh, he'd be able to do what he's trying to do in that image. So potentially a lovely activity, might be something really fun and positive to set up for the dog, but is it actually going to aggravate any particular conditions for that individual? And I would say when you watch the amount of backwards and forwards motion for that dog, because we must tailor this to the individual, who I know has got a lot of discomfort in his upper back and along the apaxial muscles, etc., and within his fascia from his neck and over his rib cage. I'd like to see that activity so he could engage with that odor without having to do the repeated rocking. So height matters, it's a good height for him, but actually the movement that he needs in order to engage with that activity was too much.
And also, just to come in quickly on that, if we are working from a point of view of being a physio or a vet, where you are deliberately creating a particular movement that you think will be therapeutic, that's one thing. But offering the dog the choice between the two is more appropriate for most of us who aren't coming from this clinical point of view. If you've ever, had a physio, you know that the physio will make you move in ways that you do not want to move. But that's because there is a specific therapeutic aim, which is coming from an educated perspective. Whereas for most of us, just thinking, oh, I'm pretty sure this would be, useful movement, I don't think is important enough that we then take that choice away from the dog.
So there are other things within the environment. We might want to think also about the presence of other dogs. Most of the time, I think we both agree, don't we, Kirsty, that enrichment's best done with the dog by themselves. If we have a dog who's multi-housed, the video clip of that dog, he lives with another dog, he gets on very well with that other dog, but we want to make sure we maximize his opportunity for choice. He doesn't feel like he's going to get pushed out of the way or have to engage with something quicker before that other individual moves in. So competition from other dogs, perhaps also from people, nice for people to sit down and just observe the dog. I see, and I know, Kirsty, you'll have seen this a lot, people feeling like, oh, yeah, but you haven't had a go at this. Come on, have a go at this. And actually, that can be feeling as a sort of competition for the dog, but it also, again, can feel luring for the dog. Oh, gosh, I need to come in proximity to that because my caregiver, the individual I have the strongest bond, is over there. Do I need to go over there? We're going to look at a video clip about that in a moment, aren't we? So we'll come back to that. So I have this phrase, and I don't know if it's the most appropriate, but, we want our enrichment to be alluring. We want it to be interesting. That's the point of it. We want it to have the potential for positive engagement, but we don't want to be luring. We don't want to force the dog into stretching or doing things in a quicker way, making them put themselves into positions that they might not want to choose. And finding that balance can be tricky, and it does involve understanding where the discomforts are within this individual, as much as it is about them making sure we do provide them with good tools.
And obviously we don't need to, I have a unit and I do bring things in deliberately for this, but the world is full of these sort of opportunities to offer our dogs more choice and variation in their environment, in the world around us. Just sort of simply in this, I can't see my cursor, but from grass to gravel to pavement, those are 3 different tactile surfaces. All 3 of those require different proprioceptive information, vestibular information to go through and processes to go through the brain. So they're all opportunities for enrichment. But again, these are being done either on a long loose lead or off lead, so the dog can actually operate under their own decision-making decisions, so that they can move to and from and avoid surfaces if it's not comfortable. The big black dog who's on the grass, he was, at this point in his life, he was about 14 at this time, and he would have a little bit of discomfort about moving onto things like gravel. So he would choose to kind of avoid the gravel area and go either on the smoother pavement or on the grassy area. But it's by giving them this choice that you can really see what their decisions are and what their choices are. So this was back in 2016, I think. It was one of the first exercises I did, and she taught me quite a lot, because as you watch her moving around, she's quite interested in a couple of bits. She comes back to her caregiver. Her mum is on the left side of the picture, and you can see that she's quite interested in the animal smells, which are connected to this small animal carrier. Again, the vet bed, the padded jack, they've all got human and different animal smells in. But you can see that she doesn't really push into the other side of the room much at all, even to go and check them out. So they're not massively interesting things, they're just some random items. But she doesn't really push into that. And there could be a couple of different reasons for this. It could be that she wants to stay closer to her mum, so she feels a little bit insecure about moving away from her in this room that she's never been in before. But it could also be the position of the umbrella has made a sort of cave situation on the other side of the room. And very often dogs, if they've got physical discomfort will kind of avoid trying to put themselves into restricted areas. So areas where there's overhanging or where they've got to kind of crouch down is obviously physically uncomfortable, but it also can be a bit off-putting. Now, the temptation for humans is to sort of help the dog. So they're like, oh, but they haven't been over to this section of the room and haven't looked at these things over here. And the temptation for humans is, well, if I go and stand over there and kind of move around that area, then maybe the dog will see it's not very scary and that they'll come and investigate as well. But obviously that what that's actually done is just removed the dog's choice, because the dog has chosen. She doesn't choose to go into that side of the room. So we can't offer autonomy and choice with one hand at the same time as taking it back with the other. If we're going to offer these choices, we have to accept the fact that the dog's choice is the correct one for them. They've decided. So in that situation, I would take that as information, and then I would maybe bring them back, a few hours later or even the following day, and just see if it's not novel. If you've already been here before, are you a bit more willing to kind of expand your range a little bit, or is there something that's still off-putting about that? But I would always rather to take it as information rather than just say, well, that's the wrong decision, so I want you to do something else in that circumstance.
We thought that we would run through a couple of case studies just to highlight, these specific considerations. So if we have, as we have in this image, an elderly dog who we know has things like neck pain and back pain and hip pain because of veterinary and vet physio examination, we've already talked about the fact, and perhaps we didn't specifically mention, but hopefully it would be obvious, we want to think about the surfaces they're walking on. Kirsty, just a moment ago, you were saying, weren't you, about the different sensations, about gravel versus smooth versus grass? And obviously really important for these dogs, it's a non-slippery surface. So in this particular image, we've got foam matting, which should provide a nice non-slippery surface throughout. We've talked about being careful of clutter, and actually perhaps this dog has got themselves into a corner that actually is perhaps a bit busy for this individual. When we look at this positioning of this dog, you can see that they found something of interest that's low down, and they're stretching down for that. And you can see how stretched they are, and that's impacting on the way that they are putting forces through the shoulder, the elbow, and of course, if you take a look at the back leg as well, the dog is, while stretching down, rocking backwards slightly. We can see increased flexion through the hock joint, as an example. Now, some of that might be coming from ligamentous increased elasticity in the ligaments of that joint in this elderly dog. So it's just about making observations. This is a snapshot in time. Doesn't mean this is inappropriate for this dog. I've just highlighted it because we can see the way the dog is standing. But what we're trying to point out is, knowing this dog has neck, back and hip pain, we want to make sure that we don't set things up to be too cluttered. We want to make sure that we don't set things up that might fall onto the dog. We want to make sure that the dog has these choices we're talking about. So what odour is it they're specifically interested in down there, or what item is it? Is that presented at different heights as well, at chest height? I believe there we've got an image of similar engagement from the same dog at a different height, as an example. So it's just, these are the sorts of things that we can really do need to think about with individuals who have chronic pain. Where is the pain in the body, and what movements, activities, are going to be most likely comfortable? Certainly what would be uncomfortable, so that we don't prolong those specific ones.
And I think that's one of the key things about when we need to be very mindful about the use of very high value, particularly food items and things that might take a long time to complete or solve, is that putting those in areas where there is the maximum amount of physical choice, being able to access it. Because as you said, this is a snapshot. She leant down, but as you know from yourself, it's like, if it's uncomfortable, you'll then kind of, oh, that's a bit, and then you'll carry on moving on. Whereas if that's something that requires you to be still, and in place for a while, then you may ignore your body's warning, kind of that, oh, that's not very comfortable, because the pate or the chicken or the, you know, the high value kind of resource is actually overpowering that sort of sense of protection and sense of self. And the last one as well is just that to be aware with older dogs that actually their teeth are very often not, you know, in fantastic shape, and they may have jaw pain, tooth pain themselves, and neck pain all related. So giving them very hard chews or very large chews, while might seem like a nice idea, can very often actually be a little bit sort of dispiriting and not the best choice.
So, you know, on this slide, we've kind of gone the other way, just, you know, make sure it's well spaced, avoiding sudden changes of direction and balance, make sure there is a choice to move away and have comfortable resting areas spaced. And of course, we're showing you images of where we've set up these activities within a dedicated unit, which Kirsty runs, the dog knows. And I've set up, and so has Kirsty, kind of pop-up places where we've set up rooms, you know, where we have people come in throughout a day, and they're not long-term setups. But a lot of us are thinking about, you know, giving advice to our clients, using this information for ourselves with dogs. And so we might just be actually bringing them into a room in a house. So, you know, just important to think about the whole room as a space, rather than just focusing, as we often do, on the one activity. You know, we're going to perhaps, like I showed earlier with the video, we're going to, you know, here's some different smells. In that case of the dog with the mesh bags in the video, they were all more herbal smells out of interest. So they were things like catnip and, you know, dried herbs, and you know, within those bags. And, you know, that's sort of what I'm thinking is of the activity, but how does that fit within the environment I've presented it in? You know, is it a well-spaced environment with a non-slip floor? Are there different choices around that? Can they move away and engage with something else if they preferred? I would have loved to have gone into a bit more detail about the value of aerobic exercise in relation to chronic pain, because, you know, we know that aerobic exercise can be very beneficial, perhaps not so much anaerobic. Dogs may move into anaerobic quicker than humans because of a whole variety of things to do with their muscle fiber types and mitochondrial setup, and their heat loss opportunities. So it's a huge topic in its own right, which is why loose leads, self-choice, being off lead, us being stiller and slower can be so valuable to allow actual choices from the dog about what speed they're moving around the environment. But if you want a nice review of exercise and pain, because it goes into the different types of exercise, and how actually, although we know that exercise can be helpful in terms of pain, it's got to be the right kind of exercise. And Dannon does quite a good job of that in the 2015. Anything else we want to talk about in terms of elderly dogs, Kirsty?
Yeah, so again, just saying that, you know, our enrichment can be much wider than just kind of a food solving or a food gathering exercise. You know, very often their worlds have become a little bit smaller and a little bit slower. So giving them social opportunities, so the opportunities to get information about, you know, dog friends maybe, but also familiar and unfamiliar people, new social experiences. And
so
just
we're talking about smell there then, aren't we, really?
Yeah.
Because for people who are listening in our heads. And yeah, hanging out with your friend can be great, but also hanging out with the smell of your friend when you're a dog, is that what we're saying? Or the smell of familiar people?
Yeah, and also you know, sort of novel odors. So it's just about, you know, we've got lots of different exercises that I think you post up quite regularly, I post up quite regularly, that can be included. So, you know, exchanging of toys, for example. So if you've got, you know, regular group of friends and things like that, dog friends or dog family, that the dog doesn't see that often, actually just sort of swapping toys and giving the dog the toy from the other dog can be quite interesting. It's having a sort of an opportunity that doesn't involve that sort of physical meeting. It was great during COVID. We used quite a bit of that during COVID.
We have a case study that we thought we'd look at the opposite, really. We'd look at a young dog because, and sadly, as we know, we are seeing osteoarthritis being diagnosed in some younger dogs, or it might be pain of other types as well. It might not be osteoarthritic pain, could be within the long bones, but also, again, it could be within viscera and all sorts of other parts of the body. Young dogs behave differently, and one of the things we know about their neurophysiological setup is that they do tend to act first and think later, and that they get their reward chemistry activated from engagement rather than anticipation. As you go through adolescence and into adulthood, you start to get as much reward chemistry released for the anticipation of the potential rather than just the engagement itself. So young dogs are quick, aren't they? And they move around faster. So, what sort of other things do we have to think about there, Kirsty?
Yeah, and again, the as you said, they tend to sort of act first and think later. So things which are tempting are probably going to be acted on rather than thought about and then acted on. Again, with the frustration, the risk of frustration is obviously also quite high. So we have to be careful that we're offering opportunities for problem solving, but at an appropriate level, because we want to stay in that threshold of, so that the dog feels success, rather than just sort of battering away at something until it sort of drops out what you can smell.
And so this, I've drawn a circle around here, and again, it's a snapshot image in the moment. Using a foreleg if you've got elbow pain isn't necessarily a bad thing. But if we are a dog who's finding this particular activity quite frustrating, or they're not able to engage easily with it, they might get repeated paw use and overextension of parts of their body, through the activity, which may have negative impacts for them. So it's about the repetitiveness, trying to avoid things where the animal seems to have to keep going, because one, we know that repetitiveness is often a sign of frustration, but also, here we're thinking about the actual pathology within the joint and what impact extending and flexing repeatedly the elbow might that individual. We've just talked about social sense, dog friends, familiar people, great for young dogs because they really, really want social engagement. Is there anything else that we might need to be thinking about young dogs that could be beneficial?
And well, novelty. I mean, I would always say with young dogs, if they can meet novel things which we want them to meet in later life calmly, one of the best ways of doing it is to meet it in a calm environment. So if we can introduce aspects of the things like livestock and things like that, we can introduce those sort of novel odors in this sort of calm, out of context place. So that then when we start to introduce them in context, as in a living, breathing, mooing or barring kind of more exciting context, then the dog's already then familiar with it. So it can be a good use of sort of for enrichment as part of our socialization and habituation programs as well with young dogs.
Yeah, and sounds as well, and we've got that on this slide here. It's not something we've talked about a lot really, and perhaps because you can't see it on the slides. How are they feeling about sounds, rainforest sounds, animal sounds, and there's a whole variety of different sounds that you can play in different ways, but again, we want to make sure there's choice, so it's not filling the whole room. We have to think that the auditory capacity of the dog is different to ours. They hear outside our range. If we're playing them a recording, then we're playing a recording of that sound within our range. Whereas actually if they're experiencing it in its natural state, so here's an example would be something like fireworks. We've recorded fireworks. They're hearing a recording of fireworks. That's different than hearing an actual firework. And to a degree that can apply to any sound potentially. So we just want to bear that in mind and make sure the dog does have the opportunity to either choose to engage or actually be able to disengage effectively, don't we really? And make sure that we keep it simple, stupid. That's what kiss it means. Young dogs, keep it simple, silly, so that we make sure things aren't too frustrating for young dogs, because that's a time of life where frustration can be maximal. And therefore that frustration, if we create it within our enrichment, is not going to lead to the most positive. Prevention better than cure. Hopefully, we've heard some about this, but we both feel that enrichment early on in life, where it's multi-sensory, not just focused on one sense, gives animals a good opportunity to develop in themselves, develop the ability to choose, the ability for autonomy and agency. That doesn't mean to say that we can't teach them, that we're in control of the situations at certain times. But the base of autonomy and agency is really important, and I know is going to be expanded on by Kathy and Bobby a bit later today in terms of resilience and its relevance to chronic pain management. That's Kirsty's information. Prognos UK, that's me, Amber Batson, Understand Animals UK. Your references are available via the PDF, and there's plenty more that can follow on from those references if you're interested. We're both delighted to have been asked to speak, aren't we, Kirsty? And we look forward to some questions.
Thank you both so much. That was a brilliant presentation. A lot of comments in the chat saying thank you. It's given people lots of ideas and they've really appreciated the practicality of it. So I think everyone's really, really enjoyed it. A couple of quite good questions have come up. So the first one is, in terms of scent, what other smells that are not food-based can be used in the home that would help positively stimulate a dog interest, i.e. are aromatherapy oils, etc. okay/safe?
So I'll just jump in on this one. So I have a couple of different points. I think natural aromas are really kind of a perfectly valid and viable thing to kind of offer to the dog. What I would say is the presentation of it could be problematic. Oils obviously give off a lot of volatile aroma. So they're very, very strong. And even for, ourselves at our human range, which isn't particularly sensitive, I can find a lot of these aromas quite overwhelming. So I would say if you're using things like oils, use maybe a drop on a cloth or something absorbent, leave it outside, and then introduce the dog to it maybe a day or two later after it's been outside for a while. And because then a bulk of the volatiles will have been given off, there'll still be a massive amount of aroma. But I would say in an enclosed setting, I probably wouldn't, unless I had a specific therapeutic concept of why I was doing it. I wouldn't just place them in the dog's environment. And actually, I'm very careful about things like that, of perfumes and things in the home and in any enclosed environment, because I think that there is a risk for it just to become so loud to the dog that they just can't escape from it. And I don't think that would be a particularly beneficial for them, because they're just unable to switch it off. They're unable to get away from it.
There's a great thing though, isn't it? A real practical thing there is, because we would think, oh, I don't know, I've put a drop of, I don't know, clary sage onto a cloth, and now an hour or two later, I can't smell it very effectively. But of course, the dog probably does have the capacity to smell it really well, even hours and hours later. So a real nice practical thing is, there's no harm in starting with an odor which we think we really can't smell, because the dog probably can. So lots of things like dried herbs or distilled aromatic waters have less volatile odor, don't they, than essential oils. But then obviously essential oils can be given the opportunity to lose some of that, fair amount of that volatile odor by exposure to the air, basically, can't they? And then we've talked a little bit about social odors, so dogs, maybe other animals, maybe horses or cats, etc. And it is thinking about, what do I want to achieve, because enrichment does not have to be relaxing and calm and quiet. It can be more arousal engaging, but obviously with the chronic pain individual, we want to make sure that it fits with our plan for that individual. But yeah, so what are, household odors, things that were around? What else have we missed, really? Kind of the odor types that aren't food based. I mean, the world is a smell.
The world is full of odors. And as a basic thing for your own dogs, just watch what your dogs are interested in. So on your next kind of trip out, when you go out for a walk, or an explore somewhere, just watch what they're interested in. What are they sniffing at? The majority of that, as Amber sort of covered, it's going to be social information. It's going to be information about the other beings in the world around you. And then things like natural products, but then I would always go for them in their base form. So as Amber said, dried herbs or fresh herbs, living plants, things like that can be interesting, and they don't have that same volatility that we have with these sort of distilled products.
Yeah. Are there any other questions, Jade?
There are, but I don't think we have time, unfortunately, because it's 10 o'clock. And I think some of the questions are just like more practical stuff, which hopefully if people follow you, they might pick up on some of that.
Yeah, I mean, we'd both be really happy, wouldn't we, Kirsty, if you can snapshot the questions and send them over to us on our Facebook pages over the next week or two. We'll try and answer some of them.
Yeah, definitely. And I think also there was a question about, which could set up a whole other discussion about, what about cats? We've talked a lot about dogs, so maybe we could have some follow up with Cam and see whether we could get some more sort of information sort of on the go at a later date. But again, everyone's saying thank you very much. It's given us a lot of food for thought. So yeah, really brilliant chats. We have got a 15-minute break now, everyone. So the next talk is at 10:15. I'd just like to thank our sponsor for this talk, who was Agria. And again, a reminder, please to check all of our sponsors out in the expo bit that you can access from the lobby. I'm just going to invite Paul back now, and we're going to be showing a cam video during our 15-minute break. But we'll see you back at 10:15.
Yeah, thanks to all of this morning's speakers. That brings us to a close for session 1. We'll begin the next session in about 13 minutes. Just quickly, we're going to hear from Cam in a short video. So we'll be back with you very shortly.
So I'm really proud to say that CAM now offers a huge range of education materials, not only for the caregiver, but also for the canine professionals and the veterinary professionals. One of my favourites is the practice trainings. Now, I used to do these in person, but what we've now done is recorded them and put them within our education centre. Each part of the team do their recorded modules, and then at the end of all members of the practice team completing, then we can support you with further coaching calls. We also offer the practice training as a live event, generally online and live. And in this situation, we bring the whole team together and the team learns together. So the content is very much tailored for our whole practice approach. In addition to the online education services that we offer, we also offer online nurse clinic training. So for all those veterinary nurses there around the world that have a passion for senior dog management and OA management, we offer an online day for you too. These are hosted at multiple points through the year and they last the whole day. So definitely sit down at 9 and not finish till 5. In addition to supporting the vet sector, we also have a course and many more planned for the canine professionals. The current course that we offer for canine professionals is an introductory course called CAM Advocate Level 1. And the concept behind this course is to bring all of us, every part of the interdisciplinary team, to the same level of baseline understanding. We also offer a number of courses for the actual caregiver, the dog owner. There is CAM Essentials, and this is a short modular course for caregivers, the owners, who have recently had their dog diagnosed. We, within 10 to 15 minutes, have to help our clients not only understand how to identify and monitor the disease, what diagnosis involves, how to create a management plan, and repeatedly change it as the disease changes. So what we've come up with is a short modular course for the caregiver so that veterinary professional can feel comfortable redirecting their owners to the modular course for them to learn at their pace in the comfort of their own home. We also have a number of other courses for the caregivers. We have a course that helps them understand the signs of pain in dogs so that they have the ability to identify them early. We have a course to help caregivers understand how to protect their dog's joints throughout life, from a young pup all the way through into senior years. There is another course where we give the caregiver the tools of how to get prepared for an upcoming surgery. Also within the CAM Education Centre, there is a course for the veterinary professional. This is an extremely comprehensive course, giving deep insight into first opinion management of this pretty complex disease. Within the Canine Arthritis Management Education Centre, we cater for all stakeholders, where we can support veterinary professionals, canine professionals, and caregivers around the world.
Thank you to Cam for this. So as we mentioned, we're going to be back at 10:15 for the next talk. So we'll see you in 10 minutes. Take the opportunity to stretch your legs, grab a tea or coffee, and we'll see you soon. Thank you.
London, it's on our doorstep, so take a note, it's going to be incredible. One more announcement before I allow these two lovelies to start talking is that we at CAM do lots of online workshops. This one is supported by Lint Bells. It's a full day's training for nursing staff. It's a great event. It's from 9 till 5, me and Evie giving you as much information about setting up your own OA clinics in-house. I believe it's for a tiny fee of £35 for the whole day. If you're interested, head over to the camonlineshop.com and you can register there. Right, that's enough of the housekeeping. These two, I'm going to have to keep in check. I know one of them very well, and she can talk the hind leg off a donkey. So I am really excited to host these two. The lovely Professor Daniel Mills, my dear, dear friend Julia Robertson, are going to be talking from a clinical behaviorist perspective and a physical therapist perspective on identifying pain. I'm going to step out, but I will be back for Q&A at the end. So get your questions in. We're hoping if they stop talking on time, that there will be space for Q&A 10 to 15 minutes at the end. Right, behave yourselves, you two. I'll see you later.
See you later.
Bye. Bye-bye. Well, we can't promise that, can we?
Well, we'll behave ourselves, but whether or not that's what Hannah wants, that's another issue.
That's true. That's true.
Hello,
right, everyone.
Let's get that. So, can you see that, Julia?
I can see that, Daniel.
Right. If you can see that, I'm assuming everybody else can see it. Morning, everybody. I'm Daniel Mills, and
I am Julia Robertson.
In case you can't tell the difference. So, right. Hang on. I've got to get rid of this. I've got a rather annoying thing at the top of my screen. Anyway, we agreed to have a chat together live, and we've put together a couple of slides just to try and keep us on track. And what we haven't done is we haven't rehearsed this, because when the two of us chat, we tend to new ideas come out and emerge, and we thought it'd be quite interesting to do that, and we want to share that experience with you. So please do ask questions. We will have time at the end, and we'll try and make sure that we keep in track there. Oh, actually, before we start, I should have a declaration of interest because the meeting is sponsored by Boehringer. In the course of my work in veterinary behaviour, Boehringer have sponsored some of my research in the development of Pexion for the treatment of behaviour problems, and also I have done webinars for Boehringer as well. So that's my declaration of interest there. Julia, do you have anything?
I have none.
Okay. So we were asked to sort of talk about our an ethical statement, and I've just reproduced the one that most vets use and people working in the medical fields, that there are 4 guiding principles for the work that we do. And I'm going to say a little bit about it because I think it's something that sometimes gets slightly misunderstood. So there are the 4 principles: respect for autonomy, beneficence, non-maleficence, and justice. Now, when it comes to respect for autonomy, I think as a vet, it's a really important thing, because I know a lot of vets get very stressed about their work and not being able to do the utmost for the animals in front of them. But when we take our oath, we have to respect the fact that the animals are owned by a client, and that client has that right of autonomy to make decisions in their animals for what they want done to their animal. And working in the field of behavior, that can be challenging, because if a client wants to train an animal in a particular way, we can, and we think we have ethical concerns about that, then we have to spend a fair bit of time trying to navigate that. So this issue of autonomy, I think, is a really important one, about balancing the needs of the client versus sort of what we want to do as veterinarians, whether it be for behavior or whether it be for pain management. And it's a reason why vets, I think, need to get much more training in human behavior change and understanding the processes that hold back. But also, I think it's really important that vets are trained to accept that rather than stress over it. At the end of the day, we do the best we can within the limits that are set by the client. And we shouldn't beat ourselves up over an inability to do that. And like most of my colleagues, I have former colleagues who have committed suicide because of the stress of the profession. So I think it's a really important thing. Any of the vets that are listening out here, is it is not our job. We have to recognize that, as I said, there are limits, and it is not our job to save every animal and to do everything. We have to respect that the limits imposed by the owner. So that's my very serious bit to start with. And as I said, I think that one of the important things to appreciate about these 4 principles is that there are trade-offs. There are no absolutes when it comes to ethics. Yes, we try to treat people fairly, absolutely in all cases, but we also have to sort of treat the animals fairly as well. And there's that balance to be struck between both the animals' needs and the owner's needs. I'm going to now hand over to Julia, because and I'm also governed by the Royal College of Veterinary Surgeons, and they have their own ethical code. A non-vet working in this field faces a lot of additional challenges, and it's one of the few things that makes me glad that I stuck with the 5 years of the veterinary degree, because you don't have to be a vet to deal with behaviour problems, but it can help an awful lot, and it makes navigating the ethical and legal issues much easier. So over to Julia.
Absolutely. Thank you, Daniel. Now, it's really interesting. Yeah, we're very passionate about all of our how we work. And as a Golemai therapist, we work within overall about ethics, but also our own. And I think one of the most important ones is working within our professional boundaries. So we know what we can work with as far as a treatment is concerned and what is not our professional sort of knowledge. So obviously always working on veterinary consent, and that is something I feel very, very passionate about. I do quite a lot of work internationally, and the UK are quite unique with their veterinary consent for non-veterinary professionals. And it's come under a lot of scrutiny, but I really feel it's important that we keep it, because I've seen some very bad changes in different countries, and I'm sure other people can agree with me. So we work within our professional boundaries, and that connected to actively work within a multidisciplinary team to ensure best practice and outcomes. We are passionate about what we do. We've seen amazing results, so of course we're passionate. However, we've got to understand that every dog that we treat is more than just soft tissue, myofascial connections, and everything else. So we've got to work with other disciplinaries, multidisciplinary team, obviously veterinary surgeons always reporting back, but also looking at other therapies that could also help the dog that we're working with. Dan has already pertained to working with the guardians. We call owner guardians, makes them feel to us a little bit more, or the dog a lot less owned, but that's just our sort of terminology, if you like. Talking to people obviously is really important within however you are sort of interfacing with the human element of your client. So we have to, like everyone, manage and assist guardians' expectations and outcomes and changes. And we're generally looking for changes within our treatments, because we're not on the curing side, we're on the changing side. Easing mobility problems, changing all sorts of the animal's perception, whether it's physical or psychological. And we use that too. We integrate our comfort scale, which is basically something we've put together based on our observations over the years. Well, I've been doing this over 22 years now, and it's an observational guide. And this we feel help the guardians observe their dogs and understand their dogs differently. So that's sort of a little bit about how we work within this ethical framework.
Okay, so I appreciate we're already 10 minutes in.
We are.
But this issue of actually balancing the needs of the client and the needs of the dog, actually, I just wonder if it is worth us having a few words about that. Because, as I said, from our perspective, we often face, when dealing with problem behavior, owners who initially find it quite hard to accept that the animal is in pain. And I think that's partly because they sort of think, well, how could I have missed this? I love my dog. And so there may be some resistance there. But to be honest, the biggest resistance for pain, in my experience, comes actually more from the referring vets. And that sounds a terrible thing to say as a vet myself. But as you know, we've invested in quite a lot of technology now in the form of force plates and thermography in order to try and produce more physical evidence. And we'll get onto the topic of pain and discomfort shortly, but to try and convince vets that there is something going on here and they need to take some action.
Yeah.
But I mean, I guess we do charge quite a lot for our consultations, and so we filter out people, but I'm sure that a lot of people are going to face those issues with clients and how much they can afford. And yeah, we do have clients because they have to pay for the follow-up, and they might want to end sooner. Generally isn't an issue once we've got them on board with the pain, but I guess that's a different situation for you, because you might say, well, this dog needs 20 sessions, and they can say, I can only afford 5.
Yeah, we don't quite work actually like that. We do work on a treatment by treatment basis, but up front, we have generally like to have a conversation with our client. And also, as I said, we do show them the comfort scale and ask them to complete this. It's better if they complete it over a period of time, like a week, rather than immediately. But how we generally work are 3 sessions. Because if we're not seeing any change in 3 sessions, then the dog is on the wrong therapy. And that's something that we stick to, really. Maybe 4 sessions, because of how we treat. We use choice, and perhaps we can talk about this choice-led treatment a little bit later. But because of that, sometimes it can be 4 treatments. But if we've not seen any change, and I said that earlier, it's more about looking at how dogs change, not just in their mobility, but we're looking at the whole thing. So we're looking at behavioral changes, and that's quite often what we see first within our first set of treatments is a slight behavioural change. So the rule for us really is 3 to 4 treatments. If no change in any direction, then we send the dog back.
So I think it's reasonable to say then, once owners are on board with the idea of pain, if they once they've accepted it in our particular case, and once they're on board, usually they've got a momentum. So pain is something they can identify with. So and then that perhaps puts the emphasis then on making sure that the vets communicate to the clients that this animal is uncomfortable. And not to worry too much, because owners do make enormous sacrifices for their pets. And pain is something that I fully understand some owners being skeptical about vet fees for this, that and the other. But when it comes to pain, they probably can relate to that. And certainly in my experience, once you start treating that pain, you can start to see quite big changes in the behavior. So pain isn't always the cause of a behavior problem, but it often exacerbates it. And when you treat the pain, often there's several behaviors that the owner is worried about. Some of those behaviors may disappear, or they might notice other changes that, oh, he's just so much better in some other way. Whereas other behaviors, they say, well, that seems to have got a little bit better. And they see that level of improvement. And I think that's really important, because if you're not a veterinarian, you're working in my field, you might make a certain level of improvement, but then it plateaus. And there's a great temptation to sort of blame the owner, saying, oh, well, they just need to push through, they've got a little bit lazy with the program, when actually it's the dog that's holding it back, because that dog is uncomfortable in that situation. So I think there's an important sort of take-home message there, to sort of, if things are not progressing. And the thing with training is, training should have predictable outcomes. And if you're not seeing the predictable outcome, then you need to think about pain. I mean, in our own clinic, overall, over 80% of our cases now, they're presented to us as behavior cases. And but in over 80% of the cases we see, there is some sort of medical problem. In the cases that I personally see, it's well over 90%. As I head up the service, I get some of the more complicated ones. So it's very unusual for me not to have a medical complication. So when people say, "Oh, don't you miss being a vet?" when they see what I do, I sort of, well, I still do it on a regular basis. But anyway, we better get going, because we're already a third of the way through. We better start talking about some of the things we've planned to talk about. That's bizarre. That's so.
Gone back. There we go.
There we go. So this is what we said that we wanted to cover. When assessing pain and discomfort, the physical and psychological dimensions of the challenge should be considered as part of an integrated evaluation. And I think it's fair to say, we'll be talking so much about multimodal, the importance of multimodal considerations.
Absolutely.
Dogs who present with a complexity of behaviours and physical dysfunction have to be considered on a case-by-case basis, as each will present and react uniquely to their own situation and perception. I think one of the important things about that is that what it also means is trying to generate the evidence base in the traditional way of evidence-based medicine is really hard, because evidence-based medicine works on population averages, and you do your controlled studies and you show that this works versus that works. Well, and I have been I am a critique of some of the stuff that is churned out in the name of evidence-based veterinary medicine, because I think it oversimplifies, especially when you're dealing with individuals in that sort of way. And one of the common mistakes that I think that is made, and we'll come to myths in a second, is that absence of evidence is taken as evidence of absence, i.e. can't see anything, so therefore the animal isn't in pain. Or I can't see anything that's important to me. And the thing is that if at a population level, if you've got a very varied population, because the animals are experiencing the discomfort in very different ways, then actually you may not have strong evidence in the traditional evidence-based medicine approach. But I could probably spend 45 minutes just talking about that, and I better move to the third thing. It is important to appreciate the direct connection between postural dysfunction and behaviour. Now, I know this is one of your hot topics that you love to go. So seeing as I had my little rant on the last bullet point, I'll let you have to say
Is it my rant? Oh, yeah. Posture for us is, I mean, the whole thing is recognizing pain and discomfort, but we look more down the discomfort because that's obviously we work within the chronic field. But posture to me is one way of really seeing through what is going on with the dog. And it's not just seeing a posture in one moment in time, it's looking at the whole. We become so geeky about it now. We literally go from the head to the tail and the tail to the nails. We look at every part of them because every part of posture tells a story. And it's not just one story, it could be a combination of stories, because we all know that compensation for any type of pain or offloading of pain or discomfort is an ongoing story. They don't just change their posture and stay like that. That then changes and morphs into another posture, into another one. So we look at almost the unwinding of myofascial connections, not the neurological side, but the myofascial side. So posture it's just such, posture and a lot of the other observations we use is such an insight into how the dog is feeling. And we know that because we work with that, we adapt postures and we see the differences. So we haven't got the evidence as such, apart from what we see and what we do and the sheer numbers of who we work with.
I know one of the things you've sort of highlighted for me is looking at dogs' nails. And I was taught about, dogs scuffing their back nails and looking for that for the nails worn. But you sort of highlighted that if as a vet you're asked to clip a dog's nails and you're only clipping some of them and not others, that tells you that the dog's not standing straight. And it, as obvious as it seems, it never had dawned on me until you pointed that out. So again, that anybody here who's a groomer who's working in that area, just be aware of that. If the nails are wearing down unevenly, the dog is probably standing and walking unevenly.
Everything comes through to the feet. Everything in the body is reflected through the feet. And of course, it's minutiae detail by the time it gets to each toe and each pad. But dogs sit on their back, stand on their back pads. So their nails almost become sort of parallel to the ground because their front toes, phalanges, are almost parallel. So or the lateral or the medial splaying of toes, all those things we look at in minutiae detail too.
Right. Okay. Let's now start. We're halfway through. Let's actually start on the things we were going to talk about. Okay. Pain versus discomfort. Do you think it's useful to distinguish between these? I'll let you go first.
Well, from our perspective, definitely, because pain is not our back. If a dog is in pain, they should be going to see the vet. That's how we work. So discomfort, definitely. Chronic discomfort, chronic pain, if you like. Acute pain, let's put that as acute pain, isn't ours. Chronic pain, discomfort, yes, that definitely is our bag. So we do, as a therapist, we like to distinguish between the two because it's important.
Yeah, I think for the same reason we've started to use the word discomfort much more, because when you talk about pain, as I said at the beginning, sometimes we have problems getting vets on board with the fact that this animal needs pain management. And since we've used the word discomfort, it's been easier. I think for some vets, you're trained in certain aspects of pain, and that shapes the way that you consider, when somebody says, well, this dog is in pain, think, well, that's not pain as I know it.
Yeah.
And that might be one of the sources of where there can be resistance. Whereas using the term discomfort actually it makes the buy-in that much easier.
Absolutely.
The other thing I find about using the word discomfort is that my sort of background work on emotions and stuff like that, discomfort is basically the brain acknowledging something isn't right. And that something isn't right. And there's an interesting whole gamut of work looking at sort of the origins of consciousness, but it probably relates to monitoring internal states. And it's just that, it's basically that thing that says, yeah, something isn't right. And the nice thing about the word discomfort is it could mean inside or outside the animal. And so you can talk about physical discomfort, you can talk about environmental discomfort, the dog is anxious and things like that. Well, the word discomfort covers both of those.
Yeah.
And also because it's just a message that says something isn't right, it allows the integration of both of those. That actually, if you're physically not 100%, you are going to be a little bit more cautious about the environment.
Absolutely.
If things are that little bit ambiguous, then they're going to feel worse if you're uncomfortable. So
absolutely, yeah.
it's one of the things, on one of the slides we're going to mention, this sort of false dichotomy between the physical and the psychological.
Completely. And also from our perspective, Daniel, the word pain, I feel, is diagnostic, and we don't diagnose.
Yeah.
So, and I know you introduced me to the word comfort and discomfort in this context a long time ago, and that's why we called it our comfort scale. And I just think that also it's not so emotive.
Yeah.
When people say, my dog's in pain, it is, as you say, it's an emotional reaction too. So we talk now about comfort and discomfort, and I find that enables people to listen more because they haven't gone into that worried state.
Okay, so let's move on then. What leads someone to present an uncomfortable animal to you? The reason why I chucked that one in is partly because we recently published some work with a former PhD student who's now the lecturer up at Edinburgh, Kevin McPeak, and Fergus Coots, who runs a pain clinic. And we looked at our caseloads, and as a behaviour person, what's interesting is that if it affects the animal's emotions, that's when, you know, they come to us. Whereas in Fergus's, who is a pain specialist, it's when it's affecting performance. And it's that aspect that tends to get latched into from that point of view. So they're quite different, the types of cases, even though they might have similar lesions. It's how it impacts on the animal. And as I said, particularly emotional changes are important in our area. I presume you're more closely aligned with the sort of cases that Fergus sees, but
yeah, I mean, mainly it's difficult. It's very varied now, and the more people understand about what we do, we have a more open variety of cases. But generally, I would think one of the biggest one is intermittent lameness. It's that idiopathic type lameness that people, I don't really know what's going on. So that is so classically for us an ongoing offloading postural change that creates that intermittent lameness. So that's one thing. Another thing, another type people come to us is when no one else knows what's going on. And I think that's when things can be so complex. If we can start unraveling the soft tissue side of things, which of course we've heard throughout this amazing symposium, how connected this all is, which working within that field, we've seen these changes. So it's lovely to have that validated. That's becoming more and more of our type of dogs that we see. So, I mean, mainly it's the mobility and the performance, as you say. Yeah, absolutely.
I think one of the things the veterinary profession isn't taught enough about, it may have changed. It's 35 years since I was at vet school, so but I don't think we're taught that much about soft tissue, discomfort, that sort of thing, other than, you know, if you tug at things when you do surgery, it hurts the animal. You know, but yeah, these sort of chronic myofascial type issues. And I remember being a meeting with Martin Fischer, the German anatomist, and he was talking about how important the fascia is in the circulation of the lymph and getting rid of waste products and stuff like that. And making sure animals have that full range of movement in their joints. You know, hip joints are not angular joints, they're rotational joints, and so dogs do need to scratch their ears and do, because that's actually what feeds the cartilage. So too much lead exercise might itself be a problem, because the animal tends to engage in a particular...
You have just opened up there in that conversation. Absolutely. I mean, two things, the myofascial connections, absolutely. It's something that we've been working with for years. It's even when I wrote my first book, I put it down then about the fascia, but now it's come on leaps and bounds with amazing people doing amazing studies and actually evidencing these kinetic lines, which is fantastic. But what you've just alluded to is something that we look at all the time, and it's one of our big assessments, and that's functional movement. And we're looking at dogs, a lot of gait assessments are on that sagittal plane. I mean, dogs should be able to move forwards because we put them on a lead, and that's how we condition them from a puppy, sadly. What we should be looking at is all these different other movements that they should be able to perform. Like you say, scratch their ear, clean themselves, all of those things. Which
we see a lot of dogs that walk, or I call it crabbing. You know, they're going in this diagonal. They won't go straight forward.
But that's
and
still
again,
on the sagittal plane, though, isn't
yeah.
it? It's just that they're shortened on one side.
Yeah, but it's something I tell people to look out for. You know, the dogs are not supposed to walk like that.
No.
They're doing that because that's the most comfortable way for them. That brings us on to the third of these points. Well, given the time, we better limit ourselves. The key things that you look for recognizing pain discomfort in your daily practice. The standout things for you.
Well, posture is one thing, but again, we look at the comfort scale. So we're also assessing different behaviors too. So we look specifically for licking and chewing of feet or other parts of their body, which we find very much, not always, but can directly correspond to a certain condition or certain restriction within that dog, because we don't work with conditions as such. We work on the effects of conditions. So any condition reflects very differently. As we were saying, every dog is different. So posture, obviously, we've already looked at that. And then we go down to looking at what they can and can't do, what type of actions they can and can't do, which planes of movement they can and can't move in, which is quite staggering, actually, how these movement planes are reduced and reduced and reduced until they can only move forwards. They can't move laterally, they can't rotate. So we look at that too. So the posture one, we look at other things too, as I said, other behaviors, how they lie, one big one that we look at, which also could come within the posture, is how they pee and poo. I mean, those are really important actions that they do every day, at least once. And if it's uncomfortable, which if a dog is having mobility problems, it will be, how they adapt. So how they adapt to be able to achieve those actions is really important as far as what is going on in the dog's body. Because if they're not defecating as much as they should, they're going to have all sorts of other problems. So everything's bound up with each other, isn't it?
Yeah.
And likewise, sort of looking at anal glands, things like that, something we can't empathize so much with. So we look at all of the dog's everyday behavior, and of course, we ask about the environment, but that's not so much recognizing, but that could be understanding what's going on.
Let me just pick up on the anal gland issue, because I think we're probably on the same page here, but other people might not know what we're talking about. A lot of people obviously know that dogs have anal gland issues, particularly I would say if you see unilateral anal glands issues. So the dog seems to be having problems with one anal gland becoming impacted. That may well indicate that the muscle movement on that side of the dog is not in the full range of movements,
not activated.
And okay, it can be bilateral and they can have two stuffed hips in that situation, but particularly if as a vet you're squeezing anal glands and one is full and one isn't, then again that well could indicate that the legs are not moving properly. Just before I move to the slide.
It's painful because of course around the glutes you've got all those, it's highly innervated around there. So it could be just really painful to actively squeeze and hold the position as well.
And I mean, from our point of view, what we tend to do is when we meet the client, we go for a little walk, and the first thing that happens is that obviously there is those emotional aspects, and they're often where there's the primary complaint, but the sorts of things that we're looking for is how the dog jumps out of the car, if the dog can jump out of the car. And I know we've got a picture to talk about of a dog jumping, but just looking to see how comfortable they are there, how they actually move. This is all before we get into the clinic and discuss anything. We just look at them. How much they do stuff like body shaking, these wet dog shakes. It's normal after they've been sat in the car for a while, they'll do it a little bit. But if they're doing it frequently, and during the whole consultation, we're looking for a lot of these little, what we call adjunctive behaviors. As I said, lots of yawning, inability to settle. If the dog's walking, how does he lie down? Now, it's okay for us, our consultations are 2 to 3 hours, and I appreciate that the average vet in practice probably has 10 minutes or less, and we have some data to suggest that dogs will inhibit a lot of this stuff in the first 10 minutes of a consultation. So, there's a good reason why many general practitioner vets might miss this stuff, because it's just not there for them to see. Yeah. And so what I encourage owners to do, and also trainers to do, is develop a portfolio, take videos, gather the evidence, and give that to the vet to look at. The other thing that I mentioned earlier that is quite important from a historical point of view, obviously, one of the things we found is if owners describe their animals as Dr. Jekyll, Mr. Hyde, that sort of temperament, like good days and bad days. But as I said before, if training should be predictable. So if things have not progressed as that you predict, whether that be the dog can't sit because he's got dysplastic hips, then you have to think about pain. But equally, with a behavior modification program, you might get so far. The other thing is that learning in the behavior problem might follow an unusual trajectory. So one of the things we found is dogs with noise fears, they will really generalize that fear from where they experience the noise far beyond what you would think is normal. So although you can see a learned association, the fact that they won't get out of the car 2 miles away from where they heard the bird scarer go off is not normal. It's normal for them to avoid the area, but if you've parked 2 miles away, gone for a walk, the dog's heard a bird scarer, you wouldn't expect the dog not to get out of their car in future. So just so you know, we have about 10 minutes left.
I know, I did have a quick look. I know, where's the time gone?
Okay, so we better very quickly cover this. So these are 2 pictures of yours that I also nicked and used in many talks.
Lumbosacral disease, so it's a diagnosed disease. So this is how he presented on the left before treatment. That was on the right, and it was just really to try and demonstrate how important looking at, well, you can obviously see the posture, but appropriate treatment for that posture. And one thing that is really overlooked so much is muscle symmetry and global muscle domination. You look at this dog's pelvic limbs, the hind legs, you'll see the hamstrings looking fantastically well toned. In fact, they're overtoned, and they are exacerbating that actual posture. So if we can go on to the next slide.
Just before we do that, though.
Oh, I'd love to spend ages on here, but
so from your point of view, but because you're dealing with that pain side, and people are coming to you with that view. But a lot of people, if they're thinking about their animal from a behavioral point of view, an emotional point of view, they see an anxious dog in the left side. And they don't realize that association with pain. So that was the point I just wanted to make before we move on to the next.
But also, this is such a sad scenario, because this particular condition, the avoidance of it actually makes the postural changes worse. And what I just wanted to show here is that we actually allow the body then to fit within the skeleton. So the soft skeleton, as it's sometimes called, the myofascial connections, can now fit more comfortably within the hard skeleton. And that is a great place to start for any other treatment to then manage any other pain associated with this condition.
I do love this picture because it just shows you on the left just how bunched up that dog is. So how all his muscles are going to be tight as a result of trying to squeeze, holding that sort of posture. And I think that a picture tells 1,000 words, so we will skip 1,000 words now.
Really does.
So this was the other thing I referred to as the jumping out. So as I said, us looking at how the dog jumps out of the car is really important. So do you want to say a few words about this picture? This is one of yours again.
I mean, what we look at is, going back to the picture and the question earlier, what do we look at as far as assessing a dog? We look at how they move. We look at how they negotiate obstacles. So walking in a straight line, as I said, it tells you quite a bit of the walk, but not so much as if you ask them to go around a corner or over an obstacle. Also, how confident are they in different situations? How confident are they on different surfaces? How confident are they holding their body before they take an action? And this picture for me demonstrates body confidence. This dog is looking where he's going. He knows his body is capable of holding himself in that position. He is confident in his movement. So that is something that I find very positive. And obviously in a lot of the dogs, we look at the confidence in movement and different activities is a really good, or lack of, is a really good assessment tool. But you would look at this the same or differently?
Well, yeah, I mean, we look at the confidence, but one of the things we see increasingly, and that's why I put the little caption at the bottom, is that dogs with this with discomfort are often quite highly frustrated. Now, if it's gone on for a longer time, they do develop a tolerance to that, but that doesn't mean that they're any much more comfortable. But clearly, if you can't move freely or with confidence, you don't have as much control over your environment, and so you get frustrated with things. So it's one of the things I've increasingly sort of looked at, is this whole issue of frustration, because I think people tend to think of anxiety in terms of fear. They think of something bad is about to happen, as opposed to the other use of the term anxiety, which means I don't know what I'm supposed to do, which is actually frustration. And but if you think about as I said, an animal that's got limited movement then has got limited autonomy.
Absolutely.
And that may well spill over.
Autonomy, huge word, autonomy. Can I just sort of go on that a little bit? Two things. Autonomy, we treat using something we call positive PACT, which is a choice-led treatment, which gives dogs autonomy within the treatment. And people often say, well, how can you treat a dog that is basically uncomfortable with choice? Well, it's amazing how potent choice is. They are sentient beings, and something that is restricted from them. I mean, I've just recently had choice removed from me within a certain area, and the frustration I feel for not being in control of that situation is huge. So choice is massive, and that could be another hour's chat, couldn't it? The other thing, talking about frustration and movement confidence, I just had a quick look at Amber's session before, and she was talking a lot about enriched environment, which is just brilliant. It's something that Turid Rugas has been talking about for ages, and it's something we use within our rehab programs, because it does work physically and emotionally. It helps with that frustration because it gives them an outlet of that freedom of movement. Again, could talk about that a lot more, but just wanted to jump in there, Daniel.
So we got to do 5 minutes on these 7 points in total. Right. So I'm going to quickly recap on some of them because we've already covered. So problems are either physical or psychological. Myth. The physical and the psychological are intricately linked. We hope we've managed to convey that to people in this session. There are specific signs of pain. So the absence of these behavioral signs means pain, discomfort cannot be present. I sort of touched on this already. The first thing is to appreciate, as I say, pain is very individual. So different animals are going to express it in different ways. And there's no one sign that tells you that this animal is in pain. There's no sign that is sufficient to indicate it. And there's no sign that is necessary for an animal to be in pain. And so, I'm a great believer that owners know their own animals. If they think something's not right, probably something isn't right.
Absolutely.
And often that is discomfort. The sub-bullet point there, lameness or unusual posture means an animal is in pain. I think it's worth us just literally 30 seconds on this, and we've got to bang through, because this is perhaps the opposite of what people might think. Lameness is one of those signs of pain. Do you want to go first? Very quickly?
Yeah, I'll quickly go first. I mean, if something's causing a lameness, I wouldn't say it's pain necessarily. I refer back to myself. I can move completely normally, but I've got all sorts of stuff going on. It doesn't mean to say that I'm in constant pain. It could be that something could trigger pain later, but it doesn't mean necessarily that the dog is in pain, but it does need to have that looked at.
Yeah, I mean, in my own case, I got run over as a teenager, so I have one leg slightly longer than the other. I move in a weird way. I'm not in pain the whole time. It's a mechanical issue. But that mechanical compensation potentially can set you up for chronic problems, and that's why it needs to be checked.
Absolutely.
Okay. Willingness to engage in certain activities like play or extended walks means the animal can't be in pain or uncomfortable. so often.
Yeah.
But he can't be in pain because he wouldn't
It loves
do
to chase
this.
a ball.
Yeah. Well, dogs live in the here and now, and we all know that, you know, then there's something really good going on, we can suppress the discomfort.
Yeah, hormones are a powerful thing.
The absence of obvious or any physical changes from diagnostic imaging indicate pain discomfort is not present.
Yes,
yes.
That is, we could, yeah.
We mentioned about soft tissue and you know, but there is, and again, there's this fallacy that there's no evidence, so it's not there.
Yeah.
And it's really important that people don't fall into that trap.
Absolutely.
As I said.
Absolutely.
We can only show, you know, lack of evidence doesn't tell us anything, unfortunately, in those situations as far as pain is concerned.
Exactly.
Certain conditions are not painful, especially if they are common in the breed type or do not require surgical intervention. Do you want to go?
Well, again, initially, maybe, but these things, like the upright stifles, the German Shepherd style, the posture, maybe not initially, but these things, if they are not moving the way the anatomy should be moving and being able to connect, there will come a time when things do become uncomfortable and need attention.
I mean,
and that's generally about 6, 7 we see something that can be just ongoing. It's normally 6, 7, 8. That's when things start to kick in and we wonder why.
So, I mean, we see a lot of cases where the animals have got subluxating patella, the kneecap slips out of the groove. And again, you know, so many people say, well, the animal doesn't yelp, so it's not painful. And you think, no, that doesn't mean that. It just means the animal's not vocalizing. And it could be a sign of, you know, greater instability in the joint, which again can contribute to the anxiety if you don't feel that stable. And, you know, the normalization of just the way that certain animals sit with their their legs tucked under, or, you know, their legs sticking out when they're lying down. And you just think, that's not normal way for dogs to sit or lie down.
Exactly.
So, in fact, I discovered that these templates for PowerPoint, there's one with a pug and he's sitting in this horrible posture, and you just think, oh, geez. Anyway. Pain is inevitable and just needs to be accepted, especially in older animals.
No.
I hope people don't need convincing on that one. There's a lot that we can do. Traditionally, people have said, oh, well, you know, the pain is protective. Well, yes, but if the animal's well managed, the animal can be pain-free.
Also, there's ageism, I find, too. That, oh, he's 9, oh, he's 10. No, we should be going, oh, he's 16, maybe. I mean, I had a 15-year-old Newfoundland, and she was pretty active right until the end. So no, older animals. And also, we mustn't accept the different shapes of animals. Postural change is insidious. It changes really slowly. We must be looking back at how our dogs looked when we first got them, whether they're puppy or adolescent or a rehome, and see how these postures change, because they don't change overnight. It takes time.
Absolutely.
And we get used to it. So it becomes normalized, which it shouldn't.
And I think that's a really important point, the fact that, a lot of the stuff that we see, as you say, is insidious, and vets are not used to that. They're used to the acute episode reducing the pain. And again, that's where they can get caught out, is that, well, he's like that, and he's been it's funny how you get more militant about pain in older animals as you get older, isn't it? And then a short or single course of analgesia didn't make an obvious difference, so the condition can't be painful. And I think the important thing here, and it goes back to one of the things said at the beginning, is the importance of multimodal. You know, for me, when we try analgesia, we're talking 6 to 8 weeks before we will make a decision on that specific drug. And that's that specific drug. It is not about pain, because you've got inflammatory pain, you've got neuropathic pain, you know, and it could well be that, you know, you've just got the wrong drug or the wrong combination of drugs, and that together, you know, 2 drugs may not touch the animal, but when put together, they make a real difference.
Absolutely. And of course, because we work with our hands, the moment we put our hands on the dog, if the dog is happy for that, we can feel how they react to our hands in so many different ways that even if they are on some form of pain control, we can still, or pain management, we can still feel what other discomfort or pain could be going on through our hands. And again, that's a lot.
Yeah.
That's another very big subject. And we don't use our hands enough.
Well, my late father always said, remember your best diagnostic tools are these and these, your eyes and your.
Absolutely, absolutely.
And I would add, as in behaviour, ears as well. Listen, a lot as well. Too often people rush for the supposedly more objective sort of blood tests and whatever, but those averages for blood tests are averages for a population. I would urge people, if you've got a young animal, get blood tests done when it's young and healthy, so you know what's the normal range for your own animal, so that as it ages you can start to see how things drift, because you don't want to wait until it's in a clear crisis before you know what's going on.
Absolutely. And likewise, we say to people, get a photo of your dog when you first got it and put that on the fridge or somewhere as a photo. Nice lateral shot, same sort of thing. Check the posture. Oh, Hannah.
And I can see that Hannah has creeped in because we're already 5 minutes over. We've got these last 4 tips, okay? So, well, individuality of cases, I think we've covered. I just want to re-emphasize that every patient is an individual. Appreciation of soft tissue issues, I think we've also said, so it's worth
but every lameness has got a soft tissue problem.
Okay.
Pre-hab and post-hab, great.
Integration of physical and psychological management, multimodal. Yes, vets have primary responsibility for pain and that sort of management, but that doesn't mean that non-vets don't have a really important role, and they have skills that we don't have as vets. There's an increasing number of vets specializing in pain clinics, etc., which are really useful. So we need to treat the animal as a whole. And then the final point, which was about owner management and making sure that owners that they adjust their expectations accordingly. As I said, we mentioned about, he likes to play and he really enjoys that. Well, we're not looking to take away his discomfort, and we sort of started by talking about owner autonomy, but we're trying to let them have a realistic view and appreciate what's going on. And I think that part of owner management is really important. I think that's where we got to. So there we go.
I don't believe it.
I'm glad it's recorded, so that because we spoke fairly quickly at times, but I hope that there's something useful for everybody there.
I've had requests of, please, can I get these 2 back on to Cam, to just leave them for an afternoon, to just chin wag away. That's fine. I'll just give you the computer.
But that's the joy of conversations, is you never know what's going to come out of it, and you change your perspectives. And I think it's something we need to do much more, across disciplines. We just need to have these conversations. And I think that's why this event is so important, that you're just hearing and you think, oh, yeah, I haven't thought about it like that, and you come out different.
Definitely. I think I learned this from Julia many years ago. We need to listen to our allied professionals. I think
absolutely
what's happening now in the vet sector has actually been happening for years, for decades, in other allied professionals, and there's got to be a mutual respect for other people's
absolutely
and
we've got to be prepared to own up where the holes are. And people say, an anecdote is an anecdote. Yes, but it's still an observation, and hypotheses come from observation, so it can be tested. And Julia and I have chatted about things, and we're working together looking at dog pain faces, etc., and it's much more complicated than it is with other species because of the variability in their faces. But some of the observations that are made, and we're just trying to think, okay, that's an interesting observation. And sometimes it was just a random event, but sometimes there's equally something really important there.
I think also we've got to understand that we're not going to have evidence for everything, because evidence creates people taking the time, years and the finances to bring this evidence to our screens. I want studies done on flooring. I think it could be as powerful as a non-steroidal. I honestly believe that. Am I ever going to be able to do a large scale
ethical
prospective study? No, I'm not.
The thing is, this is something that it's difficult for us to work with evidence-based, because we're out there doing thousands and thousands of dogs I've treated, and the Garland team also. And we see things, and like you said, Daniel, we observe things, we feel things, we see the changes, and then they become a pattern. And we can see that. But of course, it's very difficult then to have that sort of, because we're out there doing it. So we need everyone, don't we? We need the whole team of people doing it, talking about it, and then evidencing it.
And another thing, I just want to add this, because this is kind of just a little bit of a mother hen thing. Having been there myself, you can feel very threatened by other people's knowledge, and you can feel very vulnerable, and you can suddenly start feeling weak and almost out of your depth. And it takes a little bit of time to get over that and really embrace other people's experience and appreciate it and work with them, not feeling threatened by them.
Absolutely. And as I said, I just want to we will let other people ask some questions in a minute. But the thing about evidence-based medicine is that evidence-based medicine was actually developed as a way of teaching medicine, not as a way of practicing it. Then the economists got hold of it and said, oh, this is the most efficient way of us spending the money, because there's limited funds. And there's a whole, there's one of the great things is there's actually very little evidence that an evidence-based medicine approach actually improves outcomes, which I think is a brilliant finding. But and people understanding statistics is so poorly taught. It doesn't matter about statistical significance. You're interested in effect sizes. And people just don't get that. But it's so much easier, the world, when you think about effect sizes, i.e., is this a meaningful effect? What do I need for this actually to be meaningful? And you can do experiments on n=1. You give the animal medication, you take the medication away, you give it again. And, if you see that on a repeat occasions, then you've got actual quite strong evidence for that. So you mentioned about flooring. Yeah, carpet runners. Put carpet runners down, take them up. Monitor the dog's behavior. Guess what? The dog's behavior gets worse on that, and you see that repeatedly. So you can generate evidence. It just has to go in a slightly different way to the narrow view. And there are people working in evidence-based medicine who have a much broader appreciation of what it involves, but there's some really bad stuff coming out in the name of evidence-based medicine that I'm concerned about. Anyway, do you have some questions for us?
Yes. Anybody that's talking about comfort scale, Julia, how can they find access to that? Do you want to quickly send it to us and we'll put it in the delegate bag?
I can do that. Yes, I can put a link.
Julia's a technophobe, so maybe we should actually just share a website address.
Would you? If anyone wants, if you could do that, email us and we'll send you the comfort scale.
What's your website, lovely?
The website is garlandmyotherapy.com.
.com or .co.uk?
.com. We are .com.
You're .com. Good.
There's also the Tufts comfort scale for people, especially with older dogs, that I think is quite nice. It's just a way of generally monitoring your dog, and it asks just a few questions. So anybody who is an owner, I can remind me, and I will send you the link if you can't find it yourself. Are you familiar with that one, Hannah?
I have heard of that one. Yeah.
It is available as a PDF from the Tufts website. It might take a little bit of finding. If you can't find it, let me know and I'll send you the link.
Yeah,
we'll have
actually,
a PDF off.
I should share with you. Some a research student has listed all comfort scales, all pain scales.
Okay.
I'll see if I can find the PDF and all the links. And I can
We've just, in the paper that I did with Kevin and Fergus, at the end, I've sort of produced this sort of, from a behavior point of view, these are all the behavior questions that you want to ask before you start thinking that pain's not involved. And I can probably send you a copy of that as well. As long as, if it's going to be used commercially, then people have to contact us. But if people just want to use it in the part of their normal practice, then that's fine.
Yeah, perfect. I quite like this one. I'm going to pick Claire's one. If we accept that a clinical examination on a painful animal has the potential to be trauma-inducing, how can we ensure our examinations incorporate a trauma-informed care approach to reduce the risk of immediate and future psychological and physical harm, but still give us the information we need to localize a lesion? Lovely. That's going to take us to the break.
I would say that you start with your examination and you make notes of where there may be challenges to completing the examination. You know, and you don't think that you're going to make a full diagnosis on an animal that is in a lot of discomfort. You can't, but you can start to identify in what ways it is uncomfortable, start to put together. I mean, because we're not usually dealing with acute crises in these situations, yeah? So you start to identify some of the issues, you start to manage those, you then reassess and you modify accordingly. And it's an iterative process. It's a little bit like behavior, you know, too many people think that you're going to sort out a behavior case on a first consultation, and you don't. Because owners are not prepared properly, they don't have the skills to solve the problem. And so we spend a lot of time upskilling owners and making sure they've got the the necessary skills to try to resolve the problem. So in the short term, we sort of contain the issues, and then we work on that longer term goal in that situation.
I'm going to add to that because me and Julia got first-hand experience of working as this, being vet, being therapist. There's been a couple of cases we worked on where we accepted that we had to use pharmaceuticals, we had to change the environment, we had to modify the exercise, we had to do a lot in the background before we could even do any palpation.
Yeah, absolutely.
I think people are so intent on getting their hands on. They so want to get their hands on.
Yeah, and they want to take that blood sample. Well, actually, no, don't. Is it essential for the animal's life at the moment, or is it better that you actually start to work? Yeah,
but that comes down to communication, because there's a big fear that if we miss something at the beginning and we go down the wrong treatment pathway, there'll be litigation later, or there'll be blame, or there'll be social media abuse. So I think for me, I know when I'm a vet, I'm thinking, I've got to cover my back. I've got to cover my back, but I've also got the animal's interest, the owner's interest. There's many things that are, it's a bit like a little amplifier.
Well, I think you're right. It's where communication is so important. And if you get the owners on the journey with you, you don't have that issue to the same degree. Yeah, I mean, social media abuse happens, and that's just the modern world. But you just have to learn to
Can I
ignore
just make one point from our perspective?
Julia,
one. It'd be a long point. From our perspective, if we're treating a dog that is very reactive, and we obviously see a lot, then it's that safe space. And I know we were talking about the safety in me, or Tasha was earlier, which is just brilliant. And it's something we've been looking at for a long, long time. It's that choice, by giving that dog the safe environment and the choice to leave and come back. That is so potent as far as gaining trust, both with the dog, but also with the guardian too. And they can see how that relationship forms. But we have time. We allow that time. So that is the big difference. And that's why it works so well with us. And it's a whole process. I'm not breathing because otherwise you might think it's another point.
I'm going to shut up. Shut up, Obi. Shut up.
I'm just saying, well, you're telling her to shut up. I'll jump in there, because I think that is one of the really impressive things. Because, yeah, I've seen videos of Julia at work in this, and people say, well, you know, why would a painful animal allow you to do something painful? And developing that relationship, the cooperative care, is absolutely, you know, it's mind-blowing if you've not seen it. And animals will, but they've got to develop that relationship. And this is why, you know, from my point of view, we've got to be careful about some of the aversive training methods that are out there, because they destroy that relationship with the owner.
Yeah, definitely. Right, I'm going to stop now because we've got Sam Lindley next, and you're stealing her thunder. So
no. Okay. We mustn't steal
play fairly in the playground.
Okay. Absolutely, Hannah. Thank you. This is brilliant. Thank you.
What we will do is keep an eye on Cam, because what we will do is we will get these guys back. I'll let them have controls and they can have an afternoon to themselves. But that will be in the future. For now, leave delegates, head over. Sam Lindley and Toby Trimble are next. Thank you so much for your time, guys. Take care.
Take care. Bye.
Bye.
housekeeping. Again, just to remind you, please ask your questions. Like I say, we'll have time to ask them at the end. If you can try and put your questions in the Q&A box and keep any sort of general comments or chat to the chat box, that just makes it a bit easier for us. And please do sort of make any comments or ask any questions that you want. We might not get through all of them, but we are going to use the questions to potentially generate future content for canine arthritis management. So everything is like really useful to us. So this morning's talk is going to be on emotions and chronic pain. Sam is the founder of Longview Veterinary Services, which runs the pain clinics at Glasgow Vet School, the Dick Vet School in Edinburgh, and Broadleys Vet Hospital in Stirling, as well as behaviour and training services across Scotland, North England, and providing a variety of CPD. And Toby is an RCVS and EBVS specialist in veterinary anaesthesia and analgesia, and is the founder of Trimble Group, pioneering engaging, visual and memorable veterinary education. So in this talk, they're going to be teaming up to explore the emotional consequences of chronic pain and how we can employ our patients' emotions to best manage the pain experience. So I'll hand over to Paul and we'll get the video rolling.
Hello, thank you very much for joining us. My name is Toby Trimble. I'm a European specialist in veterinary anaesthesia and analgesia. I've been an anaesthetist for about 10 years or so, and I'm joined by Samantha Lindley, who is really one of the people who has formed the whole service around chronic pain management. You might think that because I'm an anaesthetist, that I know a lot about chronic pain management. And the truth is, I probably do from a physiological perspective or when I was sitting my diploma exams. But practically, I don't have a lot of experience because most of my work was around treating patients coming in for surgical interventions or having management as an inpatient. But outpatient management wasn't something I was ever particularly immersed with. And I think as a result, I am not really that confident with outpatient pain management, and particularly those chronic pain patients who come back and back and back. And I suppose that's why I'm really joined by Sam Lindley here. So Sam, thanks very much for joining me today.
Hi, Toby. Thanks. So I'm Sam Lindley and I run the chronic pain service at Glasgow Vet School. I came to chronic pain through an odd route of animal behaviour and acupuncture, and the two came together, and I've pretty much been banging on about the emotional response to chronic pain since the late 90s, and gradually that's emerged into the chronic pain service as I run it now. And the reason we thought this was going to be a good idea was because, as Toby said, we come to this from polarities. Don't ask me to treat and manage an acute pain patient. My bag is very much looking at the chronic pain. And one of the things I recognize is that the whole assessment, approach, and treatment of chronic pain for our colleagues can be really frustrating, partly because of the time involved, and partly because of what appears to be the very nuanced view we take of our patients, their pain, their behavior, and the big emotional responses we get from our owners. So we thought it would be good to compare and contrast the view of a classically trained anaesthetist dealing with acute pain and somebody who's really very much not classically trained in anything much, apart from veterinary medicine, but has spent a lot of time looking at chronic pain patients.
So really to set the scene, for me, if we take a patient that comes in for surgery, let's say it's a patient which is going to have a TPLO, it's got stifle disease, I'm very confident with having that patient in, with assessing it, making a robust plan, even if the patient has cardiovascular disease or they have other comorbidities. And I can manage them through that. I can tell you exactly which nerve block we would do and use ultrasound for placing a nerve block. I can tell you about using ketamine and paracetamol and non-steroidals and opioids to manage that patient and make sure they're as comfortable as possible during their surgery. And then on recovery, I would be able to work with the wonderful nurses that I worked with to be able to make a plan to manage that patient and get them out and get them home with some pain relief. But if that same dog comes back and it has a flare of chronic pain because despite it has stifle disease, it also has some ongoing degenerative joint disease in its other joints, that would be a situation where I'd be thinking, okay, I can give you the first and second line things I do. We might give some more paracetamol. We might decide to give that patient one of the monoclonal antibodies to be able to settle down its arthritis. But if he keeps coming back, that is where it ends up being a chronic pain case where I start thinking, I need to speak to Sam for this because there's a lot more going on. So, Sam, I suppose the question here is, my understanding from pain from a physiological perspective is about what's happening and the activation of those receptors. So, for example, we have a patient that has lots of kind of small pain stimuli, and then we get activation of the NMDA receptors in the spine, and that is amplifying those signals which are noxious. And then we get increase of those signals, and then we get that receptor turning into its activated form, and then we get amplifications of even some signals that aren't painful, and we get hyperalgesia, or worse possible, we get wind up, we get central sensitization and allodynia. So that's my physiological view. But what are we seeing kind of from the other perspective, from your side?
Yeah, and we know all this. We know it because we've been taught it. There's the NMDA system. There are all the other neurotransmitters involved. There's the endocannabinoid system, which may get depleted, we think, in chronic pain. Even more now, we've got the complication of knowing more, and the more we know, the less we know about gut and dysbiosis, and the more of a problem that is. We get an increase in inflammation. That may increase pain. And then, of course, we've got the overlying other anxieties and behavior and temperament of the patient. And this is where it all starts to get a bit messy, and where the vet as scientist starts to get a bit, okay, this is starting to get really hard to measure. But we can't measure all those neurotransmitters. We can't measure the endocannabinoid system. There's nothing, we can look at a patient and assume that the NMDA system might be the system we want to target, but it might not be. And we can't tell by looking at a patient which system, whether it's descending inhibitory pain, whether it's the NMDA system, which system we need to target. So those things are hard to measure. We know they're going on, and we need to make assumptions. But in order to know which, how much, how many, how often of our fancy pain medications or our physical interventions we need to use, we need to know the bottom line, which is how much is that patient suffering? We can be as clever as we like about all the different chemical interventions, but or processes going on, but the owner will become resistant, and we should become suspicious about the amount of medication we're using if we can't tell how much that patient needs those and how much it's suffering. And that brings us to the emotions that are involved in pain. Toby, do you even think about, I don't mean that like that, do you even think about the emotions that your patient that you're seeing looking at post-surgically is going through when it's in the kennel, when it's in the cage in the hospital?
Yeah, I think I do. I think sometimes when you're looking at patients, you're looking at kind of their general demeanour, and you're looking to see how comfortable they look, like how interactive they are, and we'll talk about kind of pain assessment scales later. But for me, I think I'm often looking at how anxious they are, because if you've got a patient that is very anxious, it does strike me as being a patient that is less comfortable in a situation, and it might be quite frightened, and that's clearly not a good emotion to have. So you also get patients that are elderly, that are geriatric, and then we see that they are becoming really, really disturbed because they're outside of their normal routine. So you see that they're not kind of comfortable there. So you think of what you can do around it. But largely, if they're really anxious, the thinking on is, okay, what can we do from a nursing perspective to make them more comfortable and to reassure them? But often, I'm often reaching for something that's going to reduce the amount of anxiety they've got, like asapromazine, would be often one I would reach for. But I don't know if it's the same level of like thinking on the really subtle indicators of pain and suffering, which I think you pick up on loads more than I do. I think often it's often a time thing, isn't it? Because the amount of time you have with the patient.
Well, there is the time thing, but there's also the comparison. Whereas you're just looking at the patient in front of you without any comparisons to how it would be in a kennel normally and how is it in normal life. It might well be that the owner would say, well, of course it's going to behave like that in the kennel. It's never been in a kennel before, or it has severe separation anxiety, or it is an anxious animal. It's never been socialized with people or dogs, and so it is anxious. But of course, that anxiety is going to increase its pain perception, and the release of cholecystokinin 8 will reduce the effectivity of your opiates. So it's still relevant, but it makes it, I think, much harder for you as an anaesthetist to say which should we be dealing with here, the anxiety or the pain that's dealing with the anxiety. We have the same issue with chronic pain, and it's a really tricky one. Should we deal with the anxiety more than the pain, or the pain more than the anxiety? But I think it can be harder for you because you're seeing the patient as much more of a snapshot than the luxury I have. I know you don't think it's a luxury, and many of our colleagues won't think it's a luxury, but I have the luxury of spending 90 minutes with our owners on the first consultation, where I talk through, and you've heard this, in intimate detail about how their pet is feeling based on their behavior, but most importantly, on how the individual behaviors of that patient have changed since the pain started. That's how we get what's important to the patient. And then if those things that are important to the patient have changed, we get a measure not only of the fact that they're suffering, but the degree of their suffering. So, for example, the classic Springer Spaniel who would go to the ends of the earth chasing a ball, if it stopped chasing the ball and won't do it at all, we can be pretty sure that patient's suffering. If it's still chasing the ball, it can still be suffering because that particular resource seems so much to that patient. So we have to bear both of those things in mind when we're asking questions. So, yeah.
Well, so one thing I wonder is that I wonder if do the tools that I have at my disposal make me lazy? And what I mean by that is, so in the amount of opioids that I have prescribed, is massive because clearly we deal with some really acute pain states. We use ketamine infusions, we use opioids, we use alpha-2 agonist infusions. We've got a whole range of different drugs, and often I'm thinking, okay, well this dog is painful post-op, so I'm going to give it an extra dose of methadone, and we're going to we implement this plan or give it this infusion. But I often think, well, you can't really give those that degree of controlled drugs, and certainly not at the same levels or intensity as you can do for an inpatient with an outpatient. So, do you need to be more resourceful and picking up on more subtle signs because you're not able to have those tools there? And I'm essentially just being like, well, okay, well, this will kind of do it, but it's kind of it's quite a big, it's like a big sledgehammer to treat a problem.
But I think that's important in acute pain, and as you know, you need to deal with acute pain well in order to guard as much as possible against that acute pain developing into chronic pain. Not treating acute pain properly is definitely a risk factor for chronic pain occurring. So those treatments we use for acute pain are great and useful. And of course, it doesn't matter very much in the short term if the patient doesn't function as well as normal, doesn't think as well as normal, doesn't relate to others as well as normal, because it's only short term. One of the reasons why we'll call them integrated interventions like acupuncture and other physical therapies and not so medically based therapies have become to the fore is because people are looking for other interventions to avoid the potential loss of function and cognition, if you like, the sedation, the wobbliness, the not quite being there that comes with some of the other medications we use. So I don't think it's really about being lazy. It's about you've got to hit that pain hard, and that's justified. When we're in that chronic situation where the owner wants the pet to be everything they always were or as much as possible, then we need to be much more subtle and refined. I like to think that I'm refined in the way that we prescribe, tinker with, alter, combine medications, physical interventions, and other therapies to get the very best we can out of our patients, because we're in this for the long haul with most chronic pain. They come to me on day one, and I'm usually still seeing them shortly before they die.
And
it's a really long-term thing.
And it's acceptable to have pain medications that make patients mildly sedated or have short-term side effects that we pragmatically make a choice when they're an inpatient and when they're convalescing from surgery or illness. But in the longer term, that becomes an issue because those medications, with, for example, a small amount of sedation or longer gut transit times, that can lead to constipation. Actually, real welfare impact. So we don't want to do that in the longer term. So you're trying to manage pain without having to have those kind of negative effects on their physiology and behaviour.
And being sleepy and tired, and some of these drugs do not give us sex. Being sleepy and tired makes you feel more painful. If you're tired, you're going to be more painful. So it's not just about being a bit sedated, but actually making the thing worse that we're trying to deal with, and masking other problems. I mean, one of the things I see in my older patients who are on multiple medications is the fact that we miss something simple like a urinary tract infection. This is very similar with older people, because they don't show the classic signs. And I assume they don't show the classic signs because they're on a shed load of pain medications. So then they're suffering. It's not a reason not to treat, but it's a reason to be cautious and careful and accept that we have to make those balances. And what tells us where that balance should fall comes back to as good an assessment as we can do of the suffering.
Sorry, carry on.
No, I'm just saying, if the patients could talk to us and tell us, it would be an easy thing. And this is a big problem with cats. So often
they're not talkative.
They're not. No, well, they are. Some of them are really chatty, but they don't say anything that we understand. There's always this thing about the kidneys, kidney function, and should we give them this? Should we give them that? And the owner resisting medication because of difficulties with medication and perceptions that cats don't need it. And it's been a frustration for a long time for us all to try to get that recognition of pain in cats. And of course, the decision about, very simply, should they go on a non-steroidal or not, if their renal function is slightly impaired, would be an easy one if the cat said, I don't want to go on like this for another year, thanks very much, give us the pain relief. Or, no, actually, I'm fine. I'd rather live for a bit longer. If they could make that, they could tell us that. So we need to be able to make that judgment. And if we could make that judgment, these decisions wouldn't be difficult. And so that's, again, why we need to come back to trying to assess that emotional impact, that emotional component of pain, which is the suffering.
So if we accept that there's a difference between the physiological effects that are going on and those behavioural effects, then the next step probably is to look at what are the different components of pain. So could you kind of talk us through that? Because I think that kind of informs kind of like the kind of next part in this process.
Yeah, we tend not to think about pain in terms of components. I certainly wasn't taught that way until very much more recently. it can be quite helpful to think of it in terms of components. And particularly when we think about how we as vets have been taught to focus our attention. So we have the sensory component of pain, which is where, the discriminative, where is the pain, and the degree of the sensation. Now, it's a bit hard to think about. This is not about suffering. So I have a sensation I call pain in my big toe. That's where the pain is. It's bad enough for me to stop what I'm doing. It's bad enough for me to stop kicking the stone that I'm kicking. I know where it is, and I know what I have to do in order to try and reduce that sensation. It is sensation. There is no emotion involved. Really important, because it directs us to where the potential problem is, helps us limit the damage. We have the motor component of pain, which are the physical changes or behaviors we adopt in order to limit the pain or to express the pain. So, for instance, an animal avoiding jumping in the car or holding its leg up, that kind of thing. So those would be the motor components. And as vets, if we think about it, it's the sensory component and the motor component that we're trained to look at. The lameness, the movement, how far can they walk, how good is their measurement on a force plate, and the sensory component, where is it? There must be a problem we can see. Where is the smoking gun of the lesion? Is it arthritis? Is it a disc in the spine? What is it that is causing the problem? Can we cut it out? Can we medicate against it? Can we block the nerves to it? What is it? And those are the two things. And frustration comes about pretty rapidly when we can't find the smoking gun of the lesion, not only for us, but also for our clients who think, again, there should be something that we can point to and say, this is what's causing your dog's problem.
Because they just want to fix, don't they? That's what they're just looking for us to fix the problem and then move on.
And one of the problems with chronic pain, and I forget this sometimes because I've been doing it for so long, and I know what I'm doing in terms of I know that I'm doing chronic pain. And it's really important to remind yourself and then the owner, actually, we're not going to fix this. I mean, sometimes I fix it, very occasionally. I discharge my patients and then I get very excited. Sometimes I discharge my patients, but mostly they stay with me forever. And it's important to remind owners, tell them, educate them that this is a chronic problem that we are not going to fix. We are not going to fix the arthritis. We're not going to fix the chronic disc. We're not going to fix the thing because we can't find out what it is in the first place. But there is a problem, and your patient, your animal, your pet has pain, and we are going to do our best to manage it. And sometimes that management will look like a lot of medications. Sometimes it will look like minimal medications and some physical interventions. It can vary because the classic chronic pain arthritis, chronic pain is dynamic. It is not the same every day. It changes according to all sorts of apparently spurious changes. People talk about the weather, obviously exercise, emotion. They doing less rather than more. Sometimes always assumption that they do more, but it might be about doing less and becoming stiff and inactive or a particular kind of behavior. So these are chronic problems, and you're right, we're not going to fix them. And it's interesting when you say to somebody, I come to a conclusion, particularly if it's a behavior consultation, and I say, well, actually, your animal has pain. And quite a lot of the time, it's very much, oh, okay, right, well, let's find out, let's do an x-ray then, find out what it is, and then we can fix it. And, yeah, it's not going to be that easy. We have to remember that a lot of these lesions that we see, a lot of these problems we see with chronic pain don't have obvious lesions. There may be no smoking gun at all, or there might be lots and lots of little guns, but none of them are actually smoking and helping us out. And we have to get over that frustration for the client as well.
So sometimes you also talk about, you use this concept of the cognitive aspect of pain, and it's not the same as, like, when I think of cognitive, I'm thinking of like, well, I'm in pain. I'm worried that I can't work. I'm worried that I can't pay the mortgage. So that's what I think about. But like, you know, I mean, we've listed it down, but do animals actually think about pain? I mean, do we? I mean, there's no way we can know that.
No, so we've got the sensory and motor components are the ones that we're focused on. The two other really important components, the one that I focus on the most, anyone who's listened to me talk for about 2 minutes will know that it's the emotional component, the affective component. Affective isn't literally emotion, slightly different, but let's talk about is the emotional component of pain, and that's what we're here to talk about today. But the cognitive component, and you're right, people go, yeah, but animals don't think about pain in the way we do. And as far as we know, they don't. The difference being that they don't, as far as we know, have the introspective and projective components of pain. So I'm not going, oh my God, what does this mean? What have I got? What is it? Have I got cancer? All those kind of things. And the projection of, well, the Labrador down the road has got hip arthritis. Look what happened to him. So they don't have that projection. Now, that is both advantageous and disadvantageous. It's advantageous because we don't have all that worry. And the worry, the more we worry about our pain and worry about what it means, what it's going to be, what could be causing it, what does it mean for ourselves, the worse the pain gets. The lesion doesn't get worse, but the pain gets worse. So animals don't have that. Which is great. As soon as they feel a bit better, like, yay, we're off down the road again. The disadvantage is we can't teach them not to be frightened of their pain. And the problem with the emotional component of chronic pain is that it makes the animal feel that it is constantly under a threat. It can't tell the difference between the real threat that is acute pain, oh my God, I need to get away from that, and something that isn't going to kill it, like chronic pain. It doesn't know that that pain coming from its knee is chronic pain and not acute pain, so it can relax about it. We find it hard enough to do that when we know that it's arthritis in our knee that isn't going to kill us. But we can do things. We can learn cognitive behavior therapy and lots of other techniques to take our mind off the pain. Animals can't do that. And because we can't teach them not to be frightened of pain, not to see the pain as a constant threat, then we often have to use more medication, more intervention than a human would. And then that comes to the perception and of our clients and sometimes our colleagues as well, is that we're way over medicating our patients. And I've heard that many times. So many, oh, take them off all this medication. They don't need this. It's too much. That's why we use so much medication and so much intervention, because we can't teach them not to be frightened. And we don't know how little pain they have to experience to be frightened of it. We can have to go on the way they express themselves, their behaviors, in order to try and judge when we got it right and correlate that with our examinations as well.
So how are we actually going to assess the patients for this? So if I'm trying to look for pain, clearly one of the first things I'm going to do is I'm going to look at the animal and I'm going to examine the animal that's in front of me when it comes in. And then I'm going to do my pre-anesthesia examination, because that's just like bread and butter. You're basically looking kind of, cardiovascular, airway, you're looking at kind of general physical exam. But I'm not going to go looking for pain in those patients. I'm not going to go doing any manipulation. I don't tend to do abdominal palpation unless there's a really good reason, because I'm looking, I'm really being hyper focused in those areas. So I wouldn't necessarily have an idea of what the animals' other pain issues are. And my colleague who might have examined it, if it's an orthopedic surgeon or if it's the neurologist, they'll say, "Oh, I found a pain response on this." I'm pretty sure with most animals, if you press hard enough, you could make a pain response. But it's that is probably like quite a crude assessment I'm doing. And then if it's post-operatively, I'll often do a pain score, and I would use the Glasgow short form composite measure pain score for dogs and cats. And that, I think that just kind of gives you an overall impression of kind of what what is happening in that moment. But it's much more important for me is looking at a trend of how well they're responding to the medications you're on. But that is, I mean, that's very different to the way that you might assess patients, isn't it?
Yeah, so you're looking, your patient has had an insult. We can call surgery that, an insult.
Orthopedic surgeons will be really happy if you say that, the insult.
I thought they might like that, yeah. So they've had an insult, hopefully has had a good outcome, a painful stimulus. And so you're assuming the pain and the pain stimulus is high as they've had the surgery, and then hopefully, obviously, your pain relief will damp that down, and you hope that they continue to improve. We don't know the stage at which we're seeing our chronic pain patients. They obviously, quite often, they're at the peak because that's when people have asked for help. But they may be improving. So again, it's looking at this comparison. What I do is I first of all talk to my owners and ignore the dog or the cat. But I don't really ignore them. I let them wander around the clinic, the consult room, or if I'm seeing them at home, obviously. And you get lots of sneaky observations in about what they're doing physically. The way they get up, get down, move around, try to scratch, fail to scratch, do all those kind of things. And I listen to the owners and the things that they're telling me and ask, obviously, I guide them through what their concerns are, ask what their concerns are, what the behavior changes are, the physical difficulties that the patient has, then watch them move officially, which is always tricky. Anyone who's trying to do an orthopedic examination at a vet school and they're on slippy floors and heading for the door or heading for the car in the car park, it's not terribly useful. So videos and things can be useful. And then I finally get my hands on the patient. Why is that important? I need to have my patients as relaxed as possible. And this is one of the things I don't think you can get around. And everybody wants a quick way of doing these things, but there isn't a quick way of doing it. Your patient needs to be as relaxed as possible. And when I board the pants off my clients for half an hour talking to them, the animal is then usually relaxed, lying down, very chilled a lot of the time. Trying to get what are subtle information from the examination for chronic pain, you need to have a relaxed patient, as relaxed as possible. Everybody knows that about examining cats, but it's the same with dogs. And rushing it and hurting them doesn't help. So although it sounds weird, I'm looking for something very different from orthopedic pain or neurological pain. And that's, you can see owners looking a bit weird. Tilly, pain's pain. But when the neurologists are looking for pain, they're looking for a degree of pain that might justify them doing spinal surgery if they find an abnormality on the MRI. The orthopods are looking for the degree of pain that would justify them maybe doing surgery or can explain why that animal is so lame. I'm looking for degrees of allodynia you've talked about, hyperalgesia. You need to be really subtle doing that. And some of the responses we get from our patients are also very subtle. Some of them have great poker faces and give absolutely nothing away. But what they can't resist is that muscle tension that you get when you palpate a painful area, or the shudder, the fasciculation over an area of allodynia. And for that, you need them as relaxed as possible. You need to be calm. You need to do things very quietly. And sometimes you look like you've done the worst pain examination in the world because it's just a quick run over. Okay, that's it. I've got all the information I need. Your animal has secondary central sensitization, or a nicer way of talking about it is an expanded and exaggerated pain field. And there is no point in doing any more. As soon as I hurt your pet, it's going to be really hard for me, A, to get any further information, and B, to examine them usefully again, because they come in anticipating the fact that it's going to hurt. And then you can't get any useful information.
So it's all well and good saying that you're just going to spend 90 minutes examining the animal, which if you have a full clinic that's dedicated to it, and you're doing a lot of it, it makes sense. But if you have got lots of patients to see and you haven't got that time, what can you do to actually find the time to do those assessments properly? Because it's it would seem impractical to do that on every single patient that comes back that isn't responding to your initial management for chronic joint degenerative joint disease. So it would seem logical to me that you're going to start to prescribe your non-steroidals, your paracetamol, your monoclonal antibodies to those patients, because you're going to have a lot of them that are going to be treated and successfully so. Then you get those outliers who need more help, or the dogs that get worse, dogs and cats that get worse. So what's the way of actually doing this and fitting it in with a normal busy clinic?
Yeah, I think that's right. I think the thing, talk about the way that we do chronic pain in an ideal world, but of course it's not going to apply to every patient in chronic pain. Although sometimes I think it's very worth knowing what the ideal is, and then saying, well, and is what I'm doing here good enough for this particular patient? And a lot of the times it will be. A lot of them will respond to non-steroidals and monoclonal antibodies, etc. I think one of the keys is to try to get from your owner at least one or two emotional measures. So everybody likes to talk about client-specific outcome measures these days, CSOMs. I think more likely it's patient-specific outcome measures, really, because it's about the patient we're talking. And is there something that you can pick up from the owner that reflects the way that their pet feels? And I mean, there are great long lists. You've seen them, Toby. Long lists. You love them, don't you? Long lists of all the different behavior changes that can occur. Basically, it's any behavior change can occur in a patient.
I think did I look at this list when I was a resident and sat looking at that in one of your consults, and I was like, so it's like anything.
Yeah, that's it. It's anything. Does your dog wag its tail as much as it used to when you come in? Yeah, that's what it could be. Anything. So, and actually, this was your really good idea, Toby. Is we looked at grouping, and others have done this as well, grouping all the behaviours into areas like activity, which would be all the running and the playing and the jumping, and emotional resilience, like they've got separation anxiety, sound sensitivity, those kind of things. Physical and social interactions, so with owners, with strangers, with other dogs, and the physical interaction with environment. Are they avoiding places? Are they frightened of noises? Those kind of things. So and you can get your owners to think about this. You don't necessarily need to stand there for ages with them in the clinic exploring it. You could say, can you go away and think about some of the behaviors that have changed with your dog, and give them some examples from those groups. You can always either email them with something or send them a sheet with it, send them away with a nice bit of paper for them to have a think about. And get them to talk about those things that have changed, and then you can use those as something else to measure. Because some of these patients, if you're using the classical chronic pain scores, are never going to walk any further, are never going to gallop, are never going to jump in and out of the car because they're not physically capable of doing so. But they may be a lot happier. They may be in spending time with the owner, which they'd stopped doing. They may have stopped getting upset about being left. They may feel basically a lot happier about life. And that's the really important thing, and will help your clients feel comfortable about the intervention you're using. If you're all looking at it going, well, it looks just as lame to me as it did last time, there's no point in carrying on giving it this then, is there? But if you say, yeah, but they're sleeping well overnight and they're getting up to greet you and they're not walking any further, but when they are walking, they're interacting more with their walk. and the cat's spending more time with the family and is eating more and drinking more. And oh, look, actually, its renal parameters have improved.
You're actually seeing that there is those behavioural indicators that the owner is seeing day to day when they're sitting in the time with their pet is actually really strong.
And that's the time when the owner's emotions often change and they become a lot happier and more relaxed about everything when they can see their pet is happy. If we keep focusing on things that aren't going to change, like lameness, they're just going to get more frustrated. But if we look at real and really important changes like their emotions, they will become more engaged and happier about how their pet's doing.
Sam, we've got just a minute left. We're nearly out of time. There's so much involved in chronic pain assessment, management, pharmacology, follow up, and like the associated kind of different techniques. I'd say that I may have might have said at the start is true, but Sam has taught me a lot, and also Sam also managed to help one of our dogs who was in chronic pain, and it did give her a new lease of life. How can the people who are watching this kind of find out a little bit more about kind of chronic pain management, all the work that you're doing?
Well, we have a chronic pain course online that people can engage in. There's lots of writing I've done over the years that engages with this. There's podcasts with Hannah's CAM group that you can see. I've just recently done something with her. So there are lots of different places where you can go to look for this information. There's a whole chapter in Sagi Denenberg's Veterinary Psychiatry. Those of you who are interested in behaviour, there's a whole chapter that I wrote there on the whole aspect of chronic pain and emotion. And yeah, if there's one thing I want you to take away from this is to remember and acknowledge without embarrassment that our patients are frightened of their pain. They have this negative emotion around their pain, and we need to acknowledge it and accept that we can't teach them not to be frightened of it. And so we need to do all we can to take that pain away.
Thank you very much for your time, Sam. Really good to discuss it from our different perspectives. I hope you found it useful, and we'll be going to the Q&A. Thank you very much.
We've got some, oh, it stopped. That's fine. I was going to say we've got some strange sound in the background. So that was a fantastic discussion, Sam. Thank you so much for that. Everyone in the chat is really enjoying it. So we have had a few questions, but I thought I'd just maybe highlight some of the discussions that everyone sort of who's watching is having. So quite a lot of discussion, and thank you everyone, because it looks like everyone's being sort of very respectful, really positive. A lot about them really appreciating sort of the difference between sort of diagnosis of issues versus kind of management, and bearing in mind that pain is an emotional response. Everyone seems to sort of really appreciate the way that you and Toby talked about it, and also having interesting discussions about how we as vets can work better with other canine professionals and physiotherapists and other people to better help our caregivers and our patients, bearing in mind that a lot of our GP vets really are time limited and we don't necessarily have the appointment times that allow us. Do you want to maybe comment on that?
Yeah, I'm going to get feedback. I don't know if everybody else is getting that.
Hi, Sam. I think, do you have the lobby live stream playing in the background? Do you know?
Not that I can see.
It is coming from your side, I think. If you can see the lobby, there is just a pause button there.
No, that's just Sorry. All I can see is it's in the vent lobby.
Yeah, sorry, it's getting very difficult to hear you with the feedback. If you just minimize this, the webinar, and then if you can find the lobby, there might be a live stream playing there, and you can just close that down and then come back into the webinar. Sorry, everyone. We'll hopefully be with you shortly.
Be my fault. I'm not
Yeah, do you have a headset or anything with you?
Sorry, do I what? Sorry?
Do you have a headset or anything you can plug in?
Not easily available.
No. Yeah, I think it's coming through. It's coming through your speakers.
Should have done it now.
Yep, perfect. Thank you.
Everybody, I'd lost it on the screen, but not on the Anyway, there we go. Apologies, everybody.
That's all right.
Might be good at chronic pain, but I'm pretty crap at technology. Okay.
We're all learning. So yeah, I was just saying there's a lot of really good discussion about how we as vets can work better with other canine professionals, like physiotherapists, to try and better help our caregivers and our patients, bearing in mind sort of time limits in veterinary practice, and also sort of maybe what tips that you have, like other people have been putting, maybe sending out questionnaires ahead of appointments and things like that, maybe having regular MOT appointments with a physio rather than with the vet, and then that information can then go to the vet where they've already done an assessment. So I don't know if you wanted to comment on that.
Yeah, I think you have to find what works for you. Some people like to keep it all, in one place, and therefore they've got all the information, and the language is the same. I work with a number of physiotherapists and probably drive them mad because I want to report after every time they see them so that I can see what's going on. And I think if you do that, you need to make sure that your language is the same as the physiotherapist, because sometimes some of the language you use is slightly different. It doesn't mean one is right or wrong. We just need to make sure we're talking about the same thing. Similarly, if you use a chiropractor, I have a very good animal chiropractor who I use, and I always prep the owners before they go. So when he mentions subluxation, it doesn't mean your animal's spine is dislocated, because people do get quite horrified about that kind of terminology. So it's as well to talk to the therapist. I know it sounds really obvious, but in a busy situation, it can be hard to go, oh, that person's really good, go and see them. And then you've actually got to spend a lot of time unpicking and explaining the language that they've used. As I say, it's not that it's wrong, it's just very different. So if you spend some time talking to your therapist first and looking at the crossover of language that you use, then it will save you a lot of time later. But yes, absolutely. I have some very difficult, very challenging patients, and it's really useful that in between me seeing them, they may see the physiotherapist, they may see the chiropractor. A lot of veterinary nurses are interested in chronic pain and have done chronic pain courses, and they may be very good at assessing patients in between times or alerting the vet to the fact that they need to be seen and medication may need to be changed. So it's a very good idea. Questionnaires, yes, I personally don't use them because I suppose I've got my timing okay, but they can be really helpful, particularly if you're starting chronic pain clinics or if you know your time's limited. And there may be lots of things as you go through that questionnaire are kicked off in your mind. Right, I think we should get bloods before this animal even comes to the pain clinic. Or has anyone actually radiographed this pet? So some things that you can get ready before you see them. There may also be additional questions that you're going to ask that you get teed up on when you see that. So all of those things are helpful. Yeah.
Thank you. A question. So someone was asking, are there pain scoring models available specifically aimed at assessing emotional states other than VAS scoring?
Yeah, the main one, I'm honestly not sure, and perhaps someone from Zoetis can answer this later, but the new Metrica stroke Vet Metrica scale, which Jackie Reed and others at Glasgow have been developing for years and years and years, is really the only one that does emotion almost entirely. It's a health related quality of life scale. It's not specifically for chronic pain. The idea is it can be used, and they didn't want to use words like chronic pain because it's about a health related quality of life, and it's almost all emotion. I was so excited when I saw it. I was in right at the beginning talking about words, and then I saw it at the end, and it's like, this is fantastic. It's all about emotion. So if you can get access to that and have access to that, then that will give you a very good emotional score.
Brilliant. Just so everyone, what was the name of that again?
Well, I'm not sure what they're calling it now. It's the new Metrica health related quality of life scale.
Okay,
somebody might have a more up to date name for it if it's been changed recently, that they might want to put in the chat.
Yeah, I was going to say, if anyone knows who's watching, just pop a little link in the chat so that everyone can see. But no, that's really good. And then someone else saying, kind of similar to what we were asking before. So how much time do you dedicate to each patient per visit in your chronic pain clinic? And do you have a check-off list of subjects to cover during the visit?
Yeah, so my first visit, I do 90 minutes. So that's a good long time. And as I say, I let the animal just move around, and I focus on asking the owner questions. I have a set of questions that essentially cover what I call my triangulation, which is to reduce the uncertainty, because we do have uncertainty. We cannot say with absolute certainty that this animal has 8 out of 10 pain or whatever. And by asking about the owner's concerns and the presenting signs, by asking about behavioural changes for that patient, and then looking at both the gait, the movement, and the examination. I know that makes 4 points, but that would make it a square and not a triangle. But gait is not always relevant for all kinds of pain. I ask all those questions, and my final thing to do is to do the examination when I've gathered all the information. That's the final part in the assessment. And then I put it all together for the owner and say how much pain there is, how much suffering there is, what we think the sources of pain are, and then, of course, vitally, what we're going to do about it, which I hope by that time have more than 5 minutes to talk about. So there is that checklist that I ask. When they come back, it's 30 minutes. From the original chronic pain consultation, from which I've written a report, I have generated a specific list of outcome measures for that patient, all the things that I think are pain related and that I want to see change. Some things might be pain related, and I'll mark those as well. It may be that those won't change. They may be related to some other thing that's going on with the pet, either medically or cognitively, if it's an elderly animal. So the first consultation generates, if you like, the check-off list for the subsequent, because people forget. Oh yeah, I'd forgotten they were licking their feet. Are they still licking their feet? No, they're not licking their feet anymore. I'd forgotten about that. So owners will forget once an animal stops doing something, unless it's been, very front and center for them.
So do you get them to keep a diary, like at home?
Yeah, you need to be careful about diaries. You can end up with a lot to read. I do if it's tricky. If there's something they're very uncertain about, or if they're really getting themselves in a pickle and focusing on the negative stuff all the time, I will get them to keep it. I'd say a chart rather than a diary. Don't go down the diary route. A very clear chart. Make sure they score something, and to help them with what to score, if you can, and then make it very clear what it is you want to see and how you want that presented. Otherwise, you're going to end up with all sorts of things, but it can be really useful.
Yeah, I think that's a really good point. Every time we ask clients, I certainly have that with other conditions where we ask them to keep a diary, and then you've got a 15-minute appointment and they present you with their novel that they've written. So yeah, I agree with you there. I think last couple, so this one might be quite interesting and helpful for sort of all of us who are thinking about referring to a pain clinic. What kind of information might be helpful for the caregiver to gather ahead of the initial assessment? And I suppose an extension of that would be for maybe referring vets. What sort of information would you find helpful for us to have included, like in history and notes and things as well?
Yeah, I mean, these days I just get a massive history through, which I've got to tease out all the information I need. So from the referring vet, I think current and past medications, and if they've got any information on reactions to that, there's no point in going on about the joys of a particular medication, and then you found buried 60 pages back that they tried that to start with and the animal had a really bad reaction. So because that's, yeah, it just doesn't feel right when you do that. So that's really helpful from the referring vet, and obviously gathering any imaging together. From the caregiver, if it's unlikely, because they don't know, some videos of the animal moving or doing whatever it is that they are concerned about. However, you want to be very clear about what it is you see. Because a bit like asking for a diary, you ask for a video and you get tiny little animal running along in the distance and you can't see anything. And you know what it's like with videos. People show you stuff and you can't see it as clearly. So be very specific about what you want. If you want the gait, the movement, do you want them on lead, off lead, not running for a ball usually, because they will just gallop. Coming back with the ball is quite helpful, because that's when you will see the bunny hopping and the slowing up and the more laboured gait. And another thing just to mention about gait, which is getting quite specific, but it's just come up a lot lately, where big dogs being walked on the lead often fall into a pacing pattern, so they're moving the legs on the same side together, which gives a rise to a suspicion of back pain. Okay, just a suspicion of. But a lot of these dogs can't get their natural pace when they're walking on the lead. Even on an extending lead, they can't get their natural pace. If they're off lead, they go into a jog or a trot, and that's their natural pace. So for some of these bigger dogs, try and make sure that you can get them off lead walking, so that you can see genuinely whether or not they're pacing, because it's such an important point. And sometimes, although I'm probably the one who started everybody going on about it, it can be overdiagnosed when actually it's just a transitional gait. They can't make it to their natural gait.
That's really interesting, and I think really helpful for sort of all of us. Thank you so much, Sam. It's been a fantastic talk. We'll just wrap it up there, but there was one quick question. A few people have asked, what is the name of the veterinary psychiatry book, and who is the author that you mentioned?
Sagi Denenberg. I think I pronounced his first name right. Sagi.
Yes.
Denenberg is Denenberg, and it's veterinary psychiatry.
Perfect, thank you. Thank you again to everyone who's watching. I think I can safely say we've all really enjoyed that discussion. There's so many comments saying thank you, Sam, so no, that was really good. We'll bring it to a close there. Remember, all your questions, we will sort of keep hold of those, and either we can put them to Sam and Toby afterwards, or like I say, we'll use them to help generate more content. We have got a 15-minute break, so the next talk will be at 12:30, and we'll be exploring off-license medications, so that will be a really helpful topic as well. If you stick around, we will be playing a video from our sponsor for this talk, who is elearning.vet. They've been helping to host the symposium, so a massive thanks to them, and I'll hand over to Paul.
Thank you, Jade, and massive thank you to Sam and to Toby for that talk. If you enjoyed that talk, Sam has actually filmed a sort of mini-series with us on the elearning.vet website on chronic pain management, top tips for chronic pain management. And if you're a VIP ticket holder at this event, you will have access to that on the elearning.vet website. Thoroughly enjoyed that. Got some very good responses there, Sam. Thank you. What we're going to do now then, Sam, if you just disappear backstage for me. Perfect. As Jade has just mentioned, we're going to go to a 15-minute break. For those of you who are unfamiliar with elearning.vet, I know most of you will be, but we are a veterinary CPD provider. We try to have a variety of different formats, teaching styles, learning formats that we present information to you with. So I'm just going to play a short video which demonstrates this. And we do have, as well as paid memberships, we also work with the sponsors, people like Elanco, who do talks on our site, which are free. And there's a free membership that any veterinary professional can sign up to, as well as a specific nurse membership or equine membership. So do take a look at elearning.vet if you are interested in CPD. So I'm just going to play this short video now to explain a little bit more, just to show you, and then we'll go to a break. Ooh, bear with me, actually. Lost the video.
elearning.vet, the veterinary CPD specialist. Bringing you the highest quality veterinary CPD from industry experts and keynote speakers. A new way of learning featuring monthly mini-series, expert panel discussions, interactive CPD quiz nights, and plenty of case studies. elearning.vet, a new way to learn. Sign up now.
Thanks, everyone. We'll end this now then. We'll see you in 10 minutes for the next talk with Andrea Tarr and Gwen Covey-Crump. Goodbye.